questions? A very good morning to all of you. We are about to start the day's proceedings. We'll start the day with an interesting panel discussion on early detection and risk reduction strategies for carcinoma breast, followed by CME lectures, poster and paper presentations. So without further delay, I would request Dr. Professor Shoumita Chatterjee ma'am to take the stage and invite the panelists. Thank you.
Good morning. Good morning. I think I saw Simran having breakfast. Can you call her? Because this was her topic yesterday. So we've stolen parts from her talk. So she should be there to see what we have stolen from her. Can you give her a call, please? Yeah, that'll be great. So since we are running a little late, and since we have to catch a train, so without much ado, I'll invite my panelists, the senior most and the evergreen Dr. Hiranmoy Bhattacharya, please. Professor Shudeb Shah. By confession, they share a congenital animosity. That's what we were told. Professor Amit Rai. I've known him ever since I've served in the government service. So a very old friend indeed. And where is my favorite? I can't see him. Where's Sharad? Oh, there she is. Sharad. My student and now my colleague. Sharad, please. So I was told that I am not allowed to stand behind them, so I will come in front. Yes, if you can see the screen. Simran, yeah, we were waiting for you because we've taken significantly from your talk yesterday. So you should be there to see what we've stolen, right? So yes, these are our panelists whom you're all familiar with, and that's me who's going to moderate the session. So these are the three issues that we are going to talk about today. Risk factors, risk reduction, and early detection. Risk factors, Simran, is what you talked about. We are just going to see how much these oldies listened to you yesterday. So if they can answer, you're successful. If they can't, the problem is theirs. So I'll start off with Sharad. Sharad, we discussed about the risk factors. I mean, we said that malignancy comes with a risk. And what are the common, we'll keep it very simple, only dedicated to the PGTs, we'll not talk big things. So we want to know that what are the common risk factors that can lead to the development of a breast cancer?
Thank you, ma'am. Yesterday, Simran very nicely, as you have said earlier, told us all the risk factors. So I'll just recapitulate what we learned yesterday.
So give me the first one only.
So first is a non-modifiable and modifiable risk factors.
Yeah.
In non-modifiable, we have the age. As the age increases, the risk increases.
So let's stick to the age. I mean, what about the age is a risk factor? Is everybody in the hall at risk?
No, the more the age, the risk factor increases with age.
Okay, so the more the age, the risk factor increases. But is that true all across the world?
No, ma'am.
Yeah.
No.
So what is it? I mean, are we any different from our counterparts in the West?
No, ma'am. We have a more risk. Today's we are seeing that sporadic cases also coming up, and their age has become from 30 onwards. You can see the risk factor increasing.
Okay, so you were saying that yes, age is one of the risk factors. Gender, we assume that the female is always the one suffering, but the point that needs to be sent across is males are equally at risk, and you too get in fact they are the more aggressive diseases. Reason being there's so little volume, so the disease spreads to the chest wall and interior much earlier. So that is another risk factors. And as Sharad said, that the risk doubles with age. So the older you get, the more riskier. So I'm at a higher risk than one of my younger counterparts, but that is to be kept in mind. And yes, as Sharad said, you can see very well that if you see the chart there, if you see the chart, you'll see that the incidence is higher in white women, followed by black, and thankfully we are at a lower risk. But that is not a reason to get complacent about, keeping us aware and knowing whether we are having an early disease, simply because our graphs are also going up very fast. I mean, Omid, I just would like to know from you that, do you think that the educational status, this attributes to a development? I mean, just the fact that I'm educated and somebody else isn't, does it really make me at a lesser risk than my counterpart?
Actually, the socioeconomic status that has got a relationship with the development of the breast cancer, because the modifiable risk factors are more in case of a higher socioeconomic status people. But as they have got a very good chance to access to the healthcare facility, so earlier detection, earlier treatment, that leads to the higher life expectancy and higher survival rate. In contrary, the lower socioeconomic people, they have got a less chance to access to the healthcare facility. So late detection, late treatment, that leads to a poor prognosis for this.
So what you're giving is something like a paradox. You're saying an educated lady is at a higher risk probably because she's studying till late, she's getting married late, she's having a child late, because of her professional demands. We have all come down to small families, less number of pregnancies. So these are all high risk factors. So an educated lady is faced to these high risk factors. But at the same time, as he said, because you're educated, you will probably pick it up, you're just more aware of it. So you will pick it up, take healthcare early. Again, so it's a paradox. So somewhere, it said that the more in the higher socioeconomic group, the higher is the risk because of the modifiable factors. But yes, if your being in a higher socioeconomic group makes you more comfortable with accessing healthcare, that is a reducible thing. So you have to put in your work on awareness and, again, educating the population to screening and self-screening. We'll come to that later. I'll come to you, sir, Rashudev, sir. So we say that all breast cancers are genetically transmitted, and Simran so beautifully elicited all the genetic factors that are, but are truly all breast cancers genetically transmitted? Sir, I think your mic is not on.
And regarding familial breast cancers, say for example, genetically transmitted.
Mic to Digbin,
all,
please.
No, gotcha. So all genetically transmitted cancers, they are familial, but all familial are not genetic. So obviously, yesterday we saw the statistics. They account for approximately 5 to 10% of cases only. And as time goes by, this is going to increase. Because previously we didn't know. When we were students, we never heard of BRCAs. Now BRCAs have come up. So we have been able to identify the factors. Maybe down the line, after a few years more, we will be able to identify more factors. So this 5-10% is going to go up gradually. Right, but still, even now, at present, we have about 60, 70, 80% sporadic, and the rest is, it comes under familial group, and out of them, we have been able to identify only about 5 to 10% which are genetically linked. We have been able to stamp them.
So for the students there, I mean, when you take a history, we tell you that you take a family history, trying to find out who else in the family has a similar disease because, as Sir pointed out, it's genetically transmitted. But Sir beautifully also pointed out that all genetically transferable. Yes, sir, could you repeat that sentence you said? So you should get it right.
All that are genetically transmitted are definitely familial, but the reverse is not true.
Right.
Right.
So I think that there are three words, and three statements which you have to be a little clear about. There's something called sporadic breast, meaning I do not have a family history, but I end up with a breast lump. That means the genetic mutation has occurred in me. I didn't carry it from my forefathers. So I have a genetic mutation and I develop it. So that's sporadic. And that, as Sir pointed out, is the highest number, 85 to 90% of. So you will be knowing it. When you take a history, most will say, no, nobody else has it in my family. So the mutation has occurred in that person. Yeah, first generation, as Sir put it. The second is the hereditary. So this is caused by inheritant mutations. First one, I mutated. Second, probably my mother had it and I got it from her. So that is hereditary. And the third is something called familial. Now you may say, then what is the difference between second and third? So the second one, hereditary, you see, is caused by inherited gene mutations passed down from a parent. But the familial is breast cancer that clusters in families. Meaning, I may be BRCA positive, which I've got from my parent, but she did not manifest it. Or I have multiple other family members who have it. So the first one is a hereditary, the second is a familial. So you should be able to distinguish between these three terms and realize that most of our patients actually fall in the sporadic. So that's 85 to 90, and the other two are about 5 to 10 each. Yes, these are the genes that Simran was talking about yesterday, BRCA 1 and 2, all of are aware. If you have a sharp mind, you can memorize the rest. If not, nobody is going to penalize you for that. So that's good enough. Fine. So to the next, Amita, I'll come back to you again. Sir, don't worry, I'll come to you. Yeah, he's scowling that I was next. Why did you take the mic away? Right. So Amita, yes. So we said we were using this word familial, where there are more numbers in the family. So how much at risk are the family members? We said it's only 5 to 10%, but how much are they at risk? Now, I'll come to models later, Amita. I would just like to know that if I am a member of a family with a familial breast cancer, how much at risk are the family members? Yeah.
If one family member, the first generation, one family members is suffering from breast cancer, the next generation, the relative risk is almost 2. And if both the generations are, both first degree relatives are suffering from the breast cancer, then the relative risk are almost 3 to 3.5. So that means that it runs in families, and the risk are more if both the lineage, that means paternal and maternal lineage are, if it involves, then the relative risk increases significantly.
Great. So what Sir said is that if you have a member in the family who is positive, obviously your risks go up. This is something I would like to say. We very leniently use the word first degree, second degree. Who's a first degree? My mother, my daughter, my sister. So one step up, down, and to the side. And who's a second degree? My grandmother, my grandchild, my grandchild again, my aunt, my mother's sister, or my niece. So this is a first degree and a second degree. And always you are asked to say that there is no history of a malignancy of breast or ovarian cancer in a first or second degree female relative, right? That's what you say in your exams. So what are the risks? So if one first degree relative has a breast or ovarian cancer, the risk becomes 3 times. If one relative with a breast cancer less than 40, so earlier detection increases the risk. And that is where, the early detection stuff, we'll come to that later, will come in again. If you have two first or second degree relative with cancer less than 60 or an ovarian cancer at any age on the same side of the family, then also the risk goes up by 3 times. So the point is, again, 3 1 or 2 degree relatives, the point goes up again. So the more numbers you have in either a first or a second degree female relative, the chance of risk goes up. And it can go up to, as Sir said, up to 3 times, defending from 1 to 3. So the point is, you have to take a family history. So we say first or second degree female relative with a history of breast or ovarian CA. Now, we said that the BRCA1 and 2 are responsible for this. Is BRCA1 and 2 responsible for any other malignancy? The answer is yes. It can be prostatic, it can be pancreatic, it could be colon. So if the patient's father had a pancreatic malignancy, there also she might get the BRCA gene from the father. So when I say first and second degree female relative with breast and ovarian cancer, the next line will be whether there is any history of pancreatic, prostatic or colonic malignancy in the family as well. So when you take family histories, there are 2 things you have to take. Female with breast and ovary, other immediate family members, first and second degree, with either prostatic, pancreatic or colonic. So that is going to complete your family history. And sir, I'm back to you. Sir, I would like you to know, like you to tell us that is menstrual and reproductive experience, does it make a woman more at risk?
Good question. Definitely. Because from our student life we used to hear the early menarche, late first pregnancy and late menopause. So early menarche, if the menarche starts before the age of 12 years, the risk increases by about 10%. And the first life, age at first live birth, that is also very significant. If it is after 30 years, it significantly increases the risk. And if the first live birth is before 18 years, it will protect the lady. How? Now it will decrease the number of periods, as well as I was reading in some book, the full-term pregnancy, there is proliferation of the terminal proliferation of the breast epithelium, and that is a protective factor. So, and if the menarche is more than, starts more than after, menopause, after 55 years, the risk is more or less double.
Right. So, see, if sir pointed out...
This is about the menarche, and the second
right.
part, second part also I told you, the pregnancy, right, or the reproductive life. And another thing I forgot to tell you, the breastfeeding.
Right. So if you see, when you take a menstrual history, this menstrual history in a breast cancer patient is very different from your others. So there you say number of days, the period, how long, what is the flow and all that. Here what we know it is age at menarche. What happens during menarche? There's a sudden surge of the estrogen. Okay. And if a girl has an early menarche, she has a longer duration of a surged estrogen. Similarly, a lady who has a late menopause, the dip in the estrogen occurs much later. So breast cancer is an estrogen-dependent tumor. So if you have a longer exposure, be it in the form of an early menarche or a late menopause, you are at higher risk. And as Sir said, that if the first childbirth, because the childbirth, there is a dip in your estrogen levels again. So if you have a late first childbirth, this is again related to with what Dr. Amit Roy said, that the socioeconomic status. Lot of us are now having our children at a later date. So we are having a sustained rise of estrogen for a longer period. That makes it at higher risk. Lactation. Lactational amenorrhea keeps the estrogen at bay. So yes, if you breastfeed the child, that's a protective measure. If you don't, your levels go up again and you get exposed. Same thing with OCP. Now the issue with OCP is, see, when we did our MBBS, the OCP was primarily an estrogen pill. That's different now. You cannot say what pill she is receiving. It may be a combination pills. So OCP is not considered that high risk a factor as it was maybe 30, 40 years back. But modern era has brought about HRT. Post-menopausal women receiving HRT. What happens? So by nature has brought down your estrogen levels. You are taking these HRT pills because of the postmenopausal symptoms that you're having, and you are pulling it up again. So that brings your risk up. But the point to be noted is, how long has the lady been receiving HRT? That is important. Somebody who's had it for 2-3 years is much lesser at risk than a lady who's maybe had it for 10 years. So if your patient says, yes, I am having HRT, ask her how long. Because the longer the duration, the more at risk she's going to be. Yes.
Can I add one line?
Please do.
I remembered one of my teachers said regarding the reproductive period and life, the breast which has denied its normal function is at increased risk.
Can you be more poetic than this? So
The
beautifully
nulliparity,
said.
the,
Nulliparity.
married, but no issue. Married, had issue, didn't breast. So the one line said as the breast which has denied its normal.
So if you realize, nature has its own perfect plan. Only when we deny nature, deny the right age for everything, the risks go up. So that's extremely beautifully put. I'll come to Shudip sir once again. Sir, any lifestyle? So these were things, partly in our control, but a lot of it, when you are going to attain menarche, menopause is not in your control, right? But are there any lifestyle associated factors?
Yeah, I mean, these days the most important lifestyle associated factor that I know of is obesity.
Shall I go and hide somewhere at the back?
No, you don't need to. So, and thing is, because this obesity is a very important factor for n number of diseases, not only breast carcinoma. So that is the biggest problem, right? So we are nowadays, sort of doing less of physical labor in various forms, and armchair, whatever, software professionals or whatever. So this thing is being put to the is taking your physical structure is taking a back seat, and that is making you more at risk. And at least in our discussion, breast carcinoma is there, but for various other things. So that needs to be addressed, and most important lifestyle factor, this is what I consider is.
So any other than obesity? Anything, any other lifestyle modifiable factors?
Yes, because nowadays you see, in our country at least, breast carcinoma is the commonest cancer for half the population. So we need to educate our girls right from the beginning that how they need to conduct themselves, at least as far as lifestyle factors are concerned. For example, we have already talked about, breastfeeding and all these things. Other than that, what we can do is, we have talked about the, we have talked about all the functions of the breast that need to be taken care of, and then again, most important thing is alcohol next to obesity, and what else? There's a third factor.
Smoking. Alcohol,
yes.
smoking somehow go hand in hand, isn't it? Yeah.
These three probably are the most
right, absolutely. So yes, alcohol, smoking, obesity, sir pointed it out so significantly, and that scares me. And a history of radiation exposure. So obviously, what sort of radiation? We are not all living in the Chernobyl area or Chernobyl locality, but yes, if the patient has had a lymphoma or something for which she has received radiation in childhood, that lady becomes at a higher risk. And yes, sir was talking about obesity. It is an independent risk factor. Point really to be noted. And a high BMI, and particularly if there is an increase in your body weight post-menopause, we somehow tend to take it for granted that this is only normal, that a lady will attain menopause and then she'll have that plump matronly look. But that hikes up her risk factors. Why does it happen? There is an increase in an endogenous estrogen level in the peripheral tissue, and that is the fat tissue. So the BMI and risk for postmenopausal breast cancer is particularly stronger for the ER/PR positive patients. I'm not saying a TNBC will not have it, but it is particularly stronger for these people. And obviously, why do we call it modifiable? Be a little conscious, be a little more active, try to keep your weight under control, particularly in the postmenopausal phase. That is the time we tend to slow down actually. But that is the time where the challenge is to keep your activity levels high so that you can have a more controlled lifestyle. Hiranmoy sir, Sir, don't scowl at me. Sir is never happy with what I ask him, so but this is for you, sir. Risk assessment models. Just tell me what you understand by that. I don't expect any of us to, actually narrate the components of the risk, but what is a basic concept? We are talking about risks, so why do we need models in the first place?
Most difficult question in this.
For the most senior person.
No. Actually, we do not do this. That is the problem. The practical experience is meager. So, so many risk assessment models has come out with its limitations, etc. The most widely used model is the Gale model, where they have taken into consideration all these risk factors we have discussed so long. The age of the patient, the age at menarche, age at first live birth, the family history, etc., etc. So next, because it didn't include the BRCA 1 or 2, that is the limitation. The limitation in the Gale model is again they have underestimated the African American. Similarly, they have not mentioned about the ductal carcinoma in situ and lobular carcinoma in situ. So these are the limitations. Then came Claus model, then Couch model, then BRCA Pro model, then finally the Kuzek model, probably Tyrer-Kuzek model. They have comprehensively included all these factors, but they have omitted some of the important, significant, though not very common, that is the diet, HRT, breastfeeding, even the Tyrer-Kuzek model has omitted all these factors. So this is all about, I know I have collected from the books because I have not read.
No, what you have collected, we are going to make use of that so that we don't they might just benefit from that.
This is all about, I know, and I think this is the most difficult question because we don't have any practical.
That's why it was exclusively for you. Okay. So when we talk about risk assessment models, what we are trying to say, they are tools. Okay, so everything, it's now AI generated, isn't it? So you put all the risk factors in a software and you see that will calculate, how much a lady is at risk. So you actually do not have to sit and calculate. The risk factors are there. You have to just tick it up and they'll come out with a score for you. And that score is going to help you, counsel your patient that yes, you are at a higher risk. Yes, you're at a lower risk. Can you take care of the modifiable factors? There are certain factors that you cannot take care of, but can you take care? So it's a tool to estimate an individual's risk of developing cancer within a certain time frame. And what is that time frame? We generally look at a 5-year time frame. So in the next 5 years, how much is the risk of me developing a breast cancer? And in my lifetime, how much is the risk? So these are the 2 things that they usually use. And yes, as Sir said, there are multiple models. For the postgrads, if you can remember the first one, we would be very happy. Okay, so there are a lot of models with the pros and cons. Some include this, some include that. But if you see, all of them basically address the risk factors that we were talking about. Okay, so yes, if you can at least remember Gale model, we'll be very happy. If you have a brilliant memory like Sir, you can memorize all of them. So that's good enough. So now that we know the risks, now that we know the risk models, we need to know that how do we reduce the risk. Just knowing that, I have a chance of developing a breast cancer in my lifetime is not good enough. I should be told what all I can do to reduce that. So that is when the question of a risk reduction comes in. So when I say risk reduction, what is it? Obviously, we've talked about all these lifestyle changes, right? So you can have changes in lifestyle. Yes, I can start, walking every morning so that I can pull my weight down. I don't smoke and drink, but yes, if I may start doing it nobody is asking to be astute and stop everything, but it should be under control. That's the whole thing. If there is a girl who is not, if there's a girl who's not planning to start a family, she may be counseled that this puts you at a higher risk. If there's a lady who's not breastfeeding, she should be told that, okay, this is going to protect you. Not only does it give life to your child, it protects you as well. So these are some of the risk reductions. That's the first bit. But there is more to it. There's more to it. Now look at the last line, the genetic counseling. I'll come to the middle two later. So if I know that I'm BRCA positive, okay, I'll share a personal anecdote. One of my very, very close friends, so she developed breast cancer around 15 years back. She has gone through the gamut of treatment, of surgery, chemo, radiation, whatnot. She was doing well. I won't say she is. She was doing well. Till 2 years back, she has now been detected with peritoneal malignancy. The same person, she's suffering again. So that's when they went back and saw that she is in fact BRCA positive. So she had 2 malignancies, both BRCA related. Now the point is, when I say genetic counseling, she's already had these 2 malignancies. What about her daughters? She has 2 daughters. So we counseled her, rather she went through counseling. She got her daughters checked. One of them is positive, the other is not. Now the point is, they are in their 20s, these 2 young girls. The one who is not can still develop it. It'll be a sporadic one. But the one who is positive has to be counseled like, look, your mom had 2 episodes of malignancy. You have to take certain care. So that is where genetic counseling comes in. And if you see that the genetic change is a very aggressive genetic change, that is when she might need to go through the 2 columns in between, that is chemo prevention and risk reduction surgeries. So hence, the first is in your hand. The second, you need to go through professional checkup and counseling. And then if it is aggressive, you might need to go in through the chemo prevention. So Amita, can I come to you and ask you that when we say chemo prevention, when we say chemo, we always think the disease is there, and now I'm giving the chemo to treat that. But when I say chemo prevention, what are we talking about?
Chemo prevention means that we will start the drugs before detection of the disease itself. It might be an endocrine factors, it might be an endocrine modifiable drugs, or mostly we use the endocrine modifiable drugs. But there are some other factors also which reduces the chance of developing breast cancer at earlier, and it prevents the breast cancer development and it spreads or the metastasis at later.
Okay, fantastic. So sir said that you need to start them on medications, okay? And what does the NCCN panel say? Okay, they have a separate panel for risk reduction strategies. They say that you can only start it after the age of 35. Point 1. They say that the Gale model risk for 5 years should be over 1.7. So you fit your data into the software and see what's the risk. They say that if your life expectancy is over 10 years, meaning if you've got to know about it when you are 60, yeah, I would still love to live till 90. But the point is, if the life expectancy of the candidate is over 10 years, then only start chemo prevention. And if there is a history of lobular carcinoma in situ. So these are the factors which will tell whether you want to give chemo prevention. So Amita, back to you once again. What chemo prevention drugs would you recommend?
Mostly it is tamoxifen, and others are there, but tamoxifen is the drug that is proven to reduce the risk itself.
Very good. That's exactly the point. See, pre-menopausal women, tamoxifen is the only agent available. So what does it do? It's a selective estrogen receptor modulator, right? So this lady who is BRCA positive has the estrogen receptors. So we are trying to block it before they start manifesting it. That's the concept. So, but in postmenopausal ladies, you have other options as well. You have the aromatase inhibitors as well, but premenopausal, tamoxifen and only tamoxifen. Since we said that it is to be started early, over 35 years, so obviously these ladies are all in the premenopausal age. So tamoxifen is the commonest chemo prevention that is to be started. I'll come to you, Sir Shudip, sir, that this is all the medical aspect of it. There are certain surgeries that we request them to take if they're at a high risk, what is called the risk reduction surgeries. So would you like to enlighten us on that?
On this, we know of a very good example, a very popular example, right? It was in
Who's the person, sir, is hinting at? No, Kaushikda is not allowed. Yes, who's the person, sir, is hinting at? Simran is not allowed either. Yes, please. Absolutely. I mean, who can forget the beautiful face? Yes, sir, please continue.
Yes, so we can talk about her because it is in the public domain right now. So it was in February 2013. She underwent a bilateral prophylactic risk reduction mammoplasty.
Sir, can you hold the mic closer, please? Yeah.
Mastectomy rather, yeah. And just taking her example, she was told that she was BRCA positive, BRCA1 positive rather.
Yeah.
And then obviously the patient wants to know that what is the risk. She was told that your risk of having breast carcinoma is around 87%. And your risk of having ovarian carcinoma is around 40 to 50%. So with this background information, and why is it so? Because her mother, she had breast carcinoma and she died at a very young age. And then obviously, she was counseled that what are her options. Her options are very simple. She was told you have to undergo a bilateral mastectomy, and of course a mammoplasty was done, and that was what she did. Not only that, after a year or two, she also underwent salpingo-oophorectomy. Right. And after these operations, now what is the risk? Has the risk for developing breast carcinoma has become zero? No. It is not zero, but very close to zero. For her, it is 5%. And because regarding ovary, it's not there. And remember, when you're talking of ovary, the operation is not just oophorectomy. It is salpingo-oophorectomy. Now, you may obviously ask why. Why salpingo-oophorectomy? Now, regarding this, I may add a few more words. When we were students, I saw my boss. He used to do very, very well radical mastectomies were the order of the day. And as I also assisted him in doing, in removing the ovaries in premenopausal women. But then it was for a different reason, because then we did not have that drug out here. Tamoxifen was not there. So we had to remove both the ovaries in premenopausal women just to address, because ERPR we knew it was there then also. So that was for a different reason, and now we are doing it for a completely different reason, for the prevention of malignancy in the ovaries. And here, as I said, we have to remove the tubes also, because it seems there are some detailed oncological information here, which I'm not very conversant right now. And the most important for us is that it is easier to do a salpingo-oophorectomy than to do just an oophorectomy.
Right. So yes, as sir said, that now the point is Angelina Jolie was counseled. So that's where the genetic counseling comes in. And not everybody with a BRCA1 and 2 positive will require a risk-reducing surgery. So here comes in the point that there are certain pathogenic genetic variant with high penetrance. That's what sir said, that this lady had a risk of 87%, which is very high. And if the other lady, there's some other lady who has a risk of, let's say, 40%. Both are risks. But somebody with such a high risk is obviously counseled to undergo the surgery. There should be a compelling family history, which Miss Angelina's mother had. And those who received radiation, we were talking about the lymphomas in childhood. So they are again people who need it. The point is, a lot of women, they are okay with the mastectomy, but they may not be okay with the salpingo-oophorectomy for fertility issues. And Miss Jolie definitely didn't have the issue because she had 6 adopted children. You're all aware of that with her partner. Now the point is that if at all she has to undergo a salpingo-oophorectomy, here opens up another avenue of discussion, and that is fertility prevention. I had not planned to bring it up, but since Sir brought it, so these ladies are again counseled that you can preserve your eggs and think about, fertility much later. So that is another option that you have to think about. Okay. So the approach for these high-risk people will be, you use a risk assessment model, you find out what is the percentage risk. And if it is high, then you suggest intervention. And when I say intervention, it is obviously not everybody will say, yes, I go for chemo prevention and surgery today. So most of them, you advise an intensified mammographic screening. And what do I understand? Biannually, starting 5 years earlier than the youngest familial breast cancer. So let's say Ms. Jolie's mother had it at 40 and aunt had it at 50. So she undergoes checking from the age of 35. And biannually meaning not once in 2 years, twice in a year. Okay. Otherwise, for others, women, we say once every year, a birthday screening sort of a thing. But you advise them biannual screening. Yes, if you give chemo prevention, as Dr. Amit Roy said, then the reduction can be to the tune of nearly 50%. And yes, as Sir said, if you can do a bilateral mastectomy, yes, the reduction, the risk can be brought down to over 90%, but none of them are 100%. That is something that the patient has to be told very clearly, because they should not expect that now that I've thrown out my boobs, I've thrown out my ovaries, I'm totally free. The risk element remains, and that is where the awareness, the consciousness, the early detection, all that comes in. So having said that, we talked about risk factors, we talked about a bit about risk reduction. None of us hopefully are at risk, but still we need to be aware. And how do we pick about early detection? Sharad, you've been left out for a long time, so I'll come back to you and ask you, how can we ensure an early detection in patients of breast cancer?
So, ma'am, this question can be divided into two parts.
Okay.
First is from the clinician's perspective. So how can a doctor help in ensuring early detection? So that is by regular screening, and especially of the high-risk people who are there.
Mm-hmm.
And then you have risk assessment models. You have to educate and make aware the patient. And you have to be available for the patient, access to healthcare. And most importantly is follow-up and monitoring.
Fantastic. So he put it so beautifully that one is the responsibility of the doctor, the second is the responsibility of the patient, and third and most importantly, it's the responsibility of society. Unless you educate, you have these camps, you have these posters being put up, so that even the last lady on the earth should be aware that there is such a disease which we have to be taken care of. So you use the word screening. What do you understand when you say screening?
We can do a mammograph for
Okay.
patients above age of 40,
Mm-hmm.
and genetic testings can be done.
Okay.
And for hereditary breast cancer, intensive screening should be done.
Yeah, as we said,
Yes,
that 5 years before the age of the youngest baby. So when I use the word screening, it's a systematic method for testing asymptomatic people. That is important. He should not, she should not, it can be a he as well, should not have already detected the lump. So it's a systematic method for testing asymptomatic people for preclinical disease, and the rationale being the treatment of disease detected in a preclinical stage will improve outcome. And here when I say outcome, it is the formation of the disease. So if the disease does happen, you are catching it at a younger age, at an earlier point. So the outcome to treatment is going to be far better. So that is what we're looking for. Shudip sir, I'll come back to you. There are certain terms we use very commonly, saying it's opportunistic screening. There is something called population screening. There's something called high-risk screening. So there are a lot of young minds here. Are they all one and the same?
The high-risk screening we have just talked about.
Yeah. So
right?
Angelina Jolie
So,
was a
yeah.
high-risk patient, right? Yeah.
And regarding population screening, I mean, and there are it is an ongoing process in the West, mainly in Europe and in the Americas, where as he said, that we will do mammography after a certain age. It has been specified, and how frequently we are going to do it. So these things are in place. So that is simple population screening, because there we will pick up the population at risk. That's all. And
Opportunistic.
Opportunistic, yes. Now, when I am faced with a clinical encounter with a lady who is in the age group where the population screening is supposed to take place, then I will obviously make a request to her. And oh yes, you have to remember that she hasn't come to me with any breast-related problems. That is one thing you have to exclude. She has come to me for entirely different reasons. And then I will take her consent and request her to please get into the screening program of breast cancer, which is in vogue. So that is opportunist screening. And I would like to know from the moderator, what is the, and make the others aware, what is the status of screening in our country?
Right.
Right now, because we know that this is now the commonest cancer in women.
Right.
Right. Yes.
Yeah, I'll come to it. So, sir, as sir said, that these are the three types of screening. And when we say opportunistic screening, a woman voluntarily goes into a medical institution to be screened or following a doctor's recommendation. Maybe she has come for a gallstone. And sir convinces that, yes, we will treat your gallstone, but you are in this age, you should get a mammogram, or if you permit, with consent, I would also like to evaluate your breast status. So that is an opportunity. So sir, the lady is taking an opportunity of an encounter with a medical personnel. You have all these executive checkups. Right? So there you will see there is a mammography in that for all the ladies. So instead of just doing a sugar and a lipid profile, which we do with age, if we also do a mammography, that is an opportunistic screening. In response to what sir said, what is the status in our country? Opportunistic screening is very opportunistic. So not all women come out for it. Not all physicians counsel the patient for it, right? Half the population in our OPD is a lady, but do we actually do an opportunistic screening? So that's not there. What were the other two that we were talking about? High-risk screening, that is actually done. But what is the percentage of the high-risk population is not as high. What is the general population? So when I say population screening, it means that the healthcare workers should go from door to door, evaluating every lady in the house. So what has our government done? We do have some studies going on, mainly in the northern part of the country, where they send the ASHA workers from home to home. And what do? They said it is too resource intensive and cost intensive. So they said we are going to check for an oral, a breast, and a cervical at the same sitting. So they basically go and ask. Oral is easier to understand, to examine. Breast, these ASHA workers have been trained just to do a preliminary breast examination. Ovarian, obviously, the cervical is much more problematic. They can at least be counseled that to come to our PHC to get a swab taken. So this is a government project that is going on.
The problem is that it is because cervical cancer has long been the commonest cancer, so at least it has gone a few feet in advance, because they now bring in ladies and take the cervical smear, and they have some they have a space in the center, you know.
Yeah, so that is provided you can convince her to come to the healthcare center.
But the problem is now breast has come up later. Cervical reached there first. So we have certain things in place for cervical cancer, but there is nothing in place for breast cancer. It is still clubbed under NCDs, you know.
Right, non-communicable
diseases and all that. So we should
But not everything is so dark, you know. So in West Bengal, we have at this moment a hub and spoke model. What does it mean? That the doctors in the periphery, in the primary health centers, they are trained by the doctors in a tertiary center as to how to do a proper breast examination. That doctor in turn trains these healthcare workers, the ASHA workers or the Anganwadi nurses or whoever. These Anganwadi workers, ASHA workers are actually in direct control with the population at large. They go for health door-to-door checkups. They go to check the child's vaccination status. They go to check for distributing ORS for diarrhea. So they are actually visiting every home. So they are told that when you go to a particular home, don't just check the vaccination of the child, also check what is the status of the mother. If you are going for ORS distribution in a diarrhea population, also check what is the status of the ladies. So this it has started in West Bengal. District by district we are spreading it. And I'm sure it is going to take time. India is a vast country with a huge population. So no population screening is going to be easy. Finance always remains. So I'm not talking about big things like a mammographic screening. How many mammographic machines can you have? Think about it in a 100-kilometer radius. How many mammographic machines do you have? So you cannot claim that every lady should come and get a mammography done. That becomes more an opportunistic thing. But if you're thinking of population, that is where, you know, these population screenings of door-to-door help, reaching out to these people, that is what is much more effective. So yes, this is in response to what Sir just said, how can we do it? And that there are 3 methods in which you can do it. Breast self-examination. Every lady is taught how to do it, okay? So that you know if there is a change in the geography of your own breast, you are the first person to notice it and then take it to your physician. Mammography-based is self-explanatory. And when I say clinical breast examination, it means that the patient's breast is examined by a doctor. So an Anganwadi doing it is not CBE. When the Anganwadi does it and tells her that there is something, you need to come to the health center for a doctor to check you up, that is CBE. So there are 2 different things, self by the patient itself, mammo, self-explanatory, and then this. Yeah, yes, sir.
And the recent NCCN guideline is that self breast examination plus clinical breast examination every 6 months by a clinician and annual mammography in less than 50 years can reduce the chance of breast cancer and the survival benefit by 18%.
1.8 is a significant number. But if you realize what did Sir say? SBE plus mammo plus CBE. The challenge in our country becomes the second 2, right? So if, Sharad, I'll come to you, Sharad. Is there any improvement with self-breast examination?
Ma'am, that has been a topic of discussion and debates for many clinicians. But having said that, self-breast examination makes the patient more proactive regarding her own health. And if any change is noticed by her, she can help in early detection. And when that self-breast examination is combined with clinical breast examination...
No, we'll just stick to the SBE now. Combined, Sir has already said. Yeah.
Yes, with radiological and histopathology, then it has seen that it improves the chances of risk.
So the next question, when you talk to your patients and you advise them SBE or self-breast, what are you going to tell them? When should they examine themselves? Sorry? No, but that does mean every day. You take 2 showers a day, so you palpate yourself twice a day. It's not that. So the thing is, there should be a fixed time. They should not become manic, you know, palpating them at every moment to see whether a lump is coming up. And when should they do it? They should be counseled that do it after your periods are over, 5 days later. That is the advice that you should give. Why so? Because in the premenstrual, perimenstrual period, the breast is turgid. It is more, I wouldn't call it edematous, that's a wrong term, it's firmer. So it is difficult, you might miss a small lump. So after 5 days, when the hormonal milieu has settled down, that is when you should. So you should tell her that yes, stand in front of the mirror and you have to show them the method of doing an SBE, but to be done only once a month. They should not become paranoid and go on examining themselves every year. But what they found is that although there has been an... Yes, sir, please, yeah.
Not only examination at that particular time of their periods, but whenever they go for any clinical encounter or get an ultrasonography done, that has to be timed to be done during that period.
Point taken, sir. So if you're getting an ultrasound for your breast, do it after your periods are over, unless it's a dire emergency. That's a different thing. But these are hardly considered dire. So that even the sonologist, for him, it's easier for him to pick up a finding. So yeah, back to SBE. They say that there has been a rapid increase in detection of benign pathologies. Every lady who comes to your OPD with a breast lump, most of them, 90 out of 100, will have a benign breast disease. The challenge is now yours to convince them otherwise, that no, this is a normal change in your breast, because they become paranoid. They say that this must be cancer. So you have to counsel them, do the necessary workup, which is outside the purview of today's talk now, and convince them that no, this is a benign, you stay under follow-up, but nothing to worry. So there has been an increase in an identification of the benign, but there is no increase in identification of cancer. We still get patients with T3, T4, T10. Okay? And then we still get patients who've detected the duct, received some sort of alternative therapy for 1 or 2 years before they come to us. Higher in rural population, lesser in urban population. Probably it's just the awareness once again. And they've said there's no improvement in breast cancer specific survival. We are not saying it's all wrong. It still has to be done. But it has not yet shown any improvement in breast cancer specific survival. But we are waiting for the time when people, all ladies, become aware, and so that this actually reflects in your data. Screening mammography, very good. It has actually, trials have shown, as Sir said, there has been a reduction in mortality. The only issue in India is we had tried it, but we said that financial considerations and just the vast population and the vast geographical extent, you cannot have a mammo machine every 100 meters or 1 kilometer also for that matter. So even though it has been proven to be a good tool in rest of the world, we have not been able to replicate those results in our population. Amita, I'll come to you. Is there any effect on incidence of mortality by implementing screening by CBE? What you said was a combination of SBE plus mammo plus CBE. But if it is only CBE, maybe opportunistic for that matter, but has that shown any increased incidence of mortality change?
Because a CBE, we can detect a small lump very early, and the patient will get treatment earlier. So the disseminated disease or chance of metastasis and the chance of mortality will be reduced. I can't remember the percentage now,
So
but
yeah, but it does
definitely,
reduce. It does reduce.
definitely there will be a reduction in the mortality if we detect the lump earlier and treat them early.
Absolutely. So it is a screening test, mind you. We are not doing a CBE for a lady who has come with a breast lump. That is a totally different chapter. We are doing CBE in a lady who does not have any breast complaint. And it is not a diagnostic test, mind you. Downstaging of the breast cancer at diagnosis, that is what Sir said. We do an early detection. And though it is less sensitive than mammographs, it is still essential in the detection of 15% of breast cancers. If you read Western literature, they will say so much of our patients were detected on screening mammography. They have nothing there, but the mammography shows them a small speculated mass. They do a tissue diagnosis, they found it to be malignancy. That is a different population, but CBE by itself can actually reduce 15% of breast cancer detection. Mind you, CBE is always done by a clinician. SBE is done by the patient herself. So you should have no confusion regarding this. So we were talking that there is so much Western literature, but we don't have our own data. This is one place where we have data. This was a study done by the Tata Memorial Group. For 20 years they did it. And I had the privilege of working with some of these people. Dr. Indranil Mitra, Dr. Rajendra Badwe were my teachers, and Pramesh was my co-PGT. So I've had the privilege of working with some of these people. And what did they say? They said that clinical breast examination conducted every 2 years by primary health workers significantly downstage breast cancer diagnosis. They tweaked it to say that they are not doctors, they are primary, the Anganwadi or the Asha workers, but they are trained to do it. The same model that we are trying to practice in West Bengal now by the hub and spoke method. So yes, it does reduce, significantly downstage the diagnosis, leads to a non-significant, let's not go into the statistical jargon, go to the third point which says, significant reduction of nearly 30% mortality in ladies over 50. So the benefit is not so much in younger women. The benefit is more in older women. Reason being the same. Younger women, denser breasts, easier to miss a swelling. Older women, lax fatty breast, easier to pick up. So the benefit was seen more in elder women because they were detected early. And they concluded that clinical breast examination should be considered for screening in LMICs like ours. We cannot afford a mammogram for the whole population. We can only train make aware the ladies to do an SB, but CBE is something that we can definitely do to our population. So this was their take-home message from that study. They had a 20-year follow-up of data collection and follow-up of their patients. Huge study, acclaimed around the world. So when I say early detection, this is a summary. It should be regular screenings by mammo and ultrasound. MR is not done for regular screenings, please mind it. Who do we do it in? Patients who are at very high risk, patients who've already had a disease, patients who are BRCA positive. These are the patients where you do an MR for screening. Here I'm talking about screening, mind you, but it's mainly a mammo ultrasound. You teach your patients to do a breast examination. You do a clinical breast examination by a healthcare provider. See, now they've modified it. They are not keeping it a clinician anymore. They are saying it's a healthcare provider, which could be a trained nurse as well, okay? And you do a genetic testing for all those who are high risk, like in BRCA1 and BRCA2. So in ending, we would like to say that what is the way forward? We say that we need to save lives. That is the underlying truth. And for that, you have to first know the risk factors. Once you know it, you can reduce the risk factors, detect the disease early, and then only you can save lives. I thank my panelists. They've been amazing, they've been enlightening, and I hope you all benefited from the knowledge that they shared with you all. Thank you so much.
Which can prevent people from getting CA breast.
And the panelists have the mic back, please.
Thing is, your diet should be in such a manner so that at least we can address the number one modifiable factors, that is obesity, right? So with one solution you can address so many problems. So that is the most important thing, and what diet we need to control obesity, I think everybody knows. We don't have to get into it. And that is the most important thing. So you cut down obesity and things should fall in place. That is the thing.
Actually, high fat diet contains the estrogen. That is the problem. So you are trying to reduce the estrogen level. So no, not whatever is tasty.
The jokes apart, they also recommend high fiber diet. Now, if you think of it, it is not exclusively for breast cancer.
High fiber.
So a good diet is going to reduce risk factors.
It should be a balanced diet.
It should be a balanced diet, no extremes of diet. And taking off from what Sir said, everything that is tasty is sinful. And you can take it in any way.
Folic acid has been seen to be protective diet. Yeah.
So that is again a very preliminary study. We do not have level 1 evidence for it. The only level 1 evidence which says is have a balanced diet and keep your fibers high, and that is going to reduce.
And I tell you, madam, another I think we are
Thank you so much, ma'am. I would request Professor Shomita Chatterjee ma'am to please hand over this certificate to Professor Hiranmay Bhattacharya sir. I will request ma'am to again to hand over this certificate to Professor Sudev Saha sir. Next, Professor Amit Roy sir. And lastly, Sharad sir. I would request Professor Saibal Mukherjee sir to please hand over this certificate to Shomita Chatterjee ma'am.
Centuries ago, Lord Moynihan described the essential qualities of a surgeon in his own ornamental way. And that still holds good. Surgery is a perfect blend of sound knowledge, seamless skill, and judicious courage. Any surgical CME is incomplete if it lacks in any scope of skill development. In our next session, we shall learn about the technical intricacies of some of the essential operative procedures of breast cancer surgery. The session will be chaired by Professor Hiranmay Bhattacharya sir and Professor Bharat Prasad sir. I would request the chairpersons to take the stage and invite the speakers for their deliberations.
So we are running late. So I will request Professor Sudev first. Sudev Saha. Okay, first ke abhi program hone. Sudev Saha, please start. Amit Rai. Amit, you start. Okay, Sudev Saha. Program. ठीक है. It's all right. I do it. So nowadays this is the topic of the day because of the breast conservative surgery, you will have to reconstruct the defect, and Professor Amit Roy will tell us how to cover that defect by tissue advancement or tissue replacement.
Hello. Good morning. Now, after a day-long discussion yesterday about the detection, the investigation, now we come to our surgical management. Basically, it should be started with Sir Professor Sudev Shah, because by history, Sir William Halsted, the father of the surgeons, he in 1894 first done the not modified radical mastectomy, it is the radical mastectomy. From there, it comes to the breast conservation surgery. As we detect early, so we can preserve the breast. So let's start. Now, what is a breast conservation surgery? Breast conservation surgery is the conserving the breast, conserving the aesthetic part, but we cure or we omit the oncological part. So it provides long-term local control of the disease along with preserving the natural shape and appearance of the breast, both aesthetic and functional. Now what is the goal? Goal is to minimize the local recurrence, that is called IBTR or ipsilateral breast tumor recurrence, though achieving a good oncological clearance and the cosmetic outcomes. Now, as I have told, the history of BCS, in 1894, Sir William Halsted, he first done the radical mastectomy because at that time, the model of the disease was the contagious spread. But in 1960, Dr. Bernard Fisher, American surgeon, he denied of that contagious spread theory into the systemic breast disease, that the breast cancer is a systemic disease that is established nowadays. Now, the NACBP 4 and 6, they proposed a positive reinforcement of BCS after 20 years of follow-up, and that is our footstep towards the solid platform of BCS. And there is an epic article by Krishna B. Claw in American Journal of Oncology that improves the understanding of BCS in quadrant wise, and he coined the basic steps of the oncoplastic breast surgery in different levels, in different quadrants, and its management at quadrant wise. Now, why? Why breast conservation surgery? Because a lady get benefited from this breast conservation surgery by the following factors. It lowers the levels of the psychological morbidity, a presence of a breast and absence of a breast that makes a lady psychologically very much deformed. Less anxiety and depression, the improved body image, improved sexuality, improved self-esteem and equivalence in terms of disease outcome for BCT and mastectomy. And this is what NACBP 6 has proved, that the survival rate, overall survival, disease-free survival rate in the over 20 years is the same as for BCS and for the mastectomy. Now what are the indications? Sir, yesterday Professor Sudev Shah has already mentioned the management of early breast carcinoma, and here comes the management of the early breast carcinoma as BCS, where the tumor is T1 or T2 with N0 or N1. The axillary management are different for N0 and N1, but the conservation surgery is same for the T1 and T2 diseases. Now, what are the contraindications? There are indications, so there must be a contraindication. There are absolute contraindications and relative contraindications. Absolute contraindications, the first one is the pregnancy, because the BCS doesn't end with the surgery itself. It must be combined with the radiotherapy, and with pregnancy we cannot give radiotherapy to the lady. That's why it is an absolute contraindication. Second one is a extensive multicentric disease. That means if it involves more than 2 quadrants of the breast, then you cannot do breast conservation surgery. inflammatory breast carcinoma, the persistently positive margin even after 2 cavity saving, and if the lady prefer for mastectomy. There are relative contraindications. What are they? The large breast cancer ratio, because with improved surgical technique and improved armamentarium, we can even deal the large cancer breast ratio to a breast conservation surgery. Unable to undergo radiation, there are situations where we cannot administer radiation to the lady, like collagen vascular disease. Though nowadays it is a relative contradiction, because some of the collagen vascular disease, they can modify the dose, they can modify the timing, and they can even do a cavity boost in collagen vascular disease also. And known BRCA mutation, this is a topic of debate, so I am not going into the details. The use of breast conservation surgery range from a simple reshaping of the breast tissue to local tissue rearrangement to the use of pedicle flap or oncoplastic techniques. So Krishna Claw, they coined this breast conservation surgery or oncoplastic surgery into 2 levels, level 1 and level 2. Level 1 means you excise the lump, you do the skin undermining, you oppose the pillars, reapproximate, and then you close the skin. But in level 2, there are different modifications that you take some tissue from other quadrant of the tissue and you fill the defect. Now the factors for oncoplastic breast surgery, that is the volume of resection. There are 4 factors. That is, the volume of resection is the main factor that gives to the cosmetic results. If we excise a 10% of breast tissue, you can lift that cavity as such, that will heal by itself. But if we do more than 10% of the resection, then you need to do some sort of oncoplastic surgery. Then the location of the primary tumor within the breast. Now the location of the primary tumor within the breast. Now all the quadrants are not forgiving. The most common site for the breast cancer is the upper outer quadrant, because it harbors the 60% of the TDLU. So that is the most forgiving quadrant for a surgeon. But the lower inner quadrant, that constitute about the 10% of the breast tissue, but that is most unforgiving, because if we excise more than 5% of breast tissue from the lower inner quadrant, that will give a bad cosmetic result. Now third one is the glandular density. The fourth one is the glandular density. Third one is the size of the present breast. That is the tumor breast volume ratio. That is important. And fourth one is the glandular density. We divide the breast into a 4 according to the density A, B, C, and D. A is the less dense and the D is the most dense breast. A is the less dense, means there is predominance of fatty tissue inside the breast. So the fat that will not withstand undermining, and there is a chance of the fat necrosis later on, that gives rise to a bad cosmetic results. And in dense breast, that is type D breast, we can mobilize the glandular tissue more widely to reshape and reapproximate the residual cavity, and that gives rise to a good cosmetic result. Now, as I have earlier said, that level 1 and level 2. Level 1 we can do up to the 20% of the volume resection. But if it is more than 20%, up to 50%, then you have to do level 2 oncoplastic breast surgery, and there is a recent term that is level 3. When we excise more than 50%, you have to bring some new tissue from the locoregional area to reshape the breast. Now, level 1. Level 1, volume excision 20%, no skin excision, no mammoplasty, and it is preferred in Drain's gland. But in level 2, there is skin is excised for reshaping, 20 to 50% of the volume are excised, mammoplasty is a must, and it is preferable in fatty breast, and fatty breast is the most preferred one, but you can do in dense breast also. Now, advantages already said. Yes. Now, there are factors, that is BCS after NSCT. NSCT is preferred in locally advanced breast carcinoma mainly to downsize the tumor. Whether we can do the breast conservation surgery in a patient of NSCT. Now, yes, we can do if there is a significant reduction of the size of the breast tumor. What we have to do, pre-NSCT marking of the tumor is mandatory by a mammography, and NSCT is preferable, or NSCT is very much beneficial in triple negative, hard to new and high oncotype, because the regression of the tumor is much more in these patients, and after completion of the NSCT, excise what is left, don't excise what was there. So, this is a simple mammoplasty, that is the racket mammoplasty. There are different mammoplasties. Here is a video where a inferior quadrant lump was there, which has been excised and breast has been reshaped by a V mammoplasty. Now, first we mark the tumor, then we mark the resection line. We are excising the breast lump. এটা ফরওয়ার্ড করব। নিচের বারটা আসছে না। না, নিচের বারটা আসছে না। Now we go up to the pectoral fascia, because taking of the pectoral fascia is beneficial to prevent the recurrence. Sorry, the fast forward bar is not working. That's why we have to see the whole video. It's a 5 minutes video. We are taking the pectoral fascia, the pectoralis pec major muscle is exposed. So we excise the tumor along with the skin. So skin excision is mandatory in a level 2 oncoplastic breast surgery. Now we orient the specimen, as you know, the short superior, long lateral, and the double suture in the dip. Now we placing the clip, because the radiotherapist, they have to know where the cavity is. This is a simple Liga clip we use. Now we are placing the incision at the intramammary fold, incremental incision. We are taking the flap from the pectoralis fascia. You see the pectoral fascia exposing the pectoralis major. We are mobilizing the intramammary fold for a tension field closure. Now we are placing the flap. We are checking the bleeding at the distal most part of the flap. It bleeds well. Now we are approximating it. It is a layered approximation, and the skin is by এই তো আবার মুশকিল। Now there are flaps from the local area that will give good cosmetic results. If the tumor is at the nipple areolar complex, that is the central tumor, what we do, the Grissotti flap is the flap of choice. Now this is the marking. First picture is the marking. Second picture is a dermoglandular flap, de-epithelialization of the skin, and this round skin island that will go and create the nipple areolar complex. Now that is the last one, that is an ICAF flap. That means anterior intercostal artery perforator flap, and there is a video where marking the perforators by audio Doppler, because it is based on the perforators, so preoperatively we mark it. And this lady has got a clinically negative axilla, so we have done a sentinel lymph node biopsy for her, and luckily the sentinel lymph node biopsy came to be negative, so we don't have to do anything else. We have marked the lump. We are injecting methylene blue dye. This is the flap marking bearing the perforators. We are just marking the flaps. Then we will excise the tumor through the upper skin edge. You can see the dye, the methylene blue dye in the cavity. We have picked the lump, and the excision of the lump is by the palpatory method. No other method is available. That's why palpatory method, you palpate the lump, you take a good amount of healthy tissue, 1 centimeter at least in a 3-dimensional, and we excise the lump. Now we are doing the sentinel lymph node biopsy. So that is the cavity. We are placing the clips. Four at the fore margin and 2 at the base. We are de-epithelializing the skin because that surface will go inside. That's why intact, we cannot keep the intact skin. We have to de-epithelialize it. Initially I have missed the plane, that's why there is an amount of bleeding. Later I have corrected myself. Now we are elevating the flap. We have to go up to the fascia covering the intercostal muscle. We are trying to identify the perforator, though it is not possible always. Yes, you can appreciate the fascia covering the intercostal muscle. See, the flaps must be held by a wet gauze, not by any instrument. You can see, now you can see the perforator at the center. I'm trying to dissect it. Now I'm assessing whether it is mobile enough to fill the cavity. And now we are closing. That is the final result.
Thank you, Professor Roy. The videos were excellent.
Thank you, sir.
And if you have any question, only one question is allowed from the audience. Do you have any question? No question. May I ask you one question?
Yes, sir.
What is your idea about the acellular dermal matrix?
Sir, I haven't used because it is not available. But acellular dermal matrix is a beautiful armamentarium for a breast implant. If we cover the breast implant with acellular dermal matrix, the rejection of the implant and migration of the implant is much lesser than if we do the conventional surgery.
Thank you. Thank you.
You mark the perforators preoperatively using the Doppler.
Yes.
Now, as you said, that intraoperatively it is not always feasible to visually identify the perforators. Can the Doppler be repeated intraoperatively to identify?
Yes, it can be. No. Just leave it like that. Because the vessels in the tissue are very slender. If we fix, that will change the angulation, then there may be a marginal necrosis.
It is just going to be kept in place by the flap.
Yeah.
Okay, thank you. So next speaker is Professor. Okay, next.
Laptop
Professor Sudev Shah, please. He will talk on MRM. So Professor Sudev Shah will tell us the very commonly done operation, that is the modified MRM.
Yes, so a few words on mastectomy, its complications and management. A short history, as Dr. Amit Roy was telling, Halsted, it was in '94 that William Stewart Halsted described radical mastectomy, which involved removal of almost everything, right, except for the ribs and intercostal muscles. Everything else was removed, right? And we had I particularly, people like me, Hiren Moida, Dr. Shoibal Mukherjee, and maybe many of you, we had the privilege of witnessing these operations, which were being done in our student days very regularly, because there was nothing else to do other than radical mastectomy at that time, right? And I remember my boss, he did it so well, removed everything, you know, and remove major, minor, all the axillary lymph nodes, and we would only preserve these nerve to latissimus dorsi and serratus anterior and all that, and nothing else was there. And later on, Pate and Dyson, they described a modified radical mastectomy which involved preservation of major muscle and things were even modified further and because it was proved beyond doubt that there was hardly anything to lose by doing a MRM, and survival and disease-free survival, all these statistics, I mean, they were almost the same. Now come down to indications. Not going into them very much, but then large tumors, multicentric disease, diffuse microcalcifications as seen in the mammogram, history of previous breast or chest wall irradiation, BRCA positive tumors, local recurrence at least twice following BCS, and of course the patient's preference. So all these are the indications for mastectomy. For skin and nipple sparing mastectomy is early breast cancers, DCIS, tumor is less than 3 centimeters, more than 1 centimeter away from the skin and 2 centimeters away from the nipple. So this is skin and nipple sparing mastectomy. So these things we have already discussed, not going into it. Pre-op planning, again it is known to everybody. So this is the usual position of the patient, where the ipsilateral superior extremity is also brought in the operating field, and so that the surgeon can mobilize the arm while doing the operation. It is kept in that manner. Anesthesia is always general with endotracheal intubation. And let's come down to the incision. So it's nowadays a transverse incision, whereas in case of radical mastectomy it was an oblique incision. And in certain cases, in certain patients, you will have to slightly modify the tumor this way or that way, right? So mostly it's transverse. And whatever is, what do we include? We always include the nipple areolar complex, the skin overlying tumor, and there has to be a 1 or 2 centimeter margin on either side. And these are the boundaries where you perform your operation: laterally, anterior margin of latissimus dorsi, medially the parasternal edge, superiorly level of the second rib, inferiorly the inframammary crease. But then as shown here, it is not, you are not supposed to use these instruments nowadays. It should always be the hook, right? And it is always, you have to remove the upper flap first. Can I have the answer why from the students? It is always the upper flap first and never the lower flap. The reason is simple, because most of the vascularity comes from top. And this is where you have to keep in mind that one of the most common complications that you're going to have later on is necrosis of the flaps. So this is where you have to address the problem. You have to make sure that you keep at least some amount of, you shouldn't be going too far, or too far. By that I mean you should be keeping optimum amount of fat with the flap. It is conventionally said that it should be around 7 to 8 millimeters, right? Not more and not less. Exposure of the pectoral muscles. The breast parenchyma and pectoralis fascia elevated from the underlying pectoralis major muscle till the lateral edge and pectoralis minor muscle is exposed. So, and while doing that, the medial and pectoral nerve, which actually supply these pectoral muscles, they have to be preserved. And that it will come in the next step, actually, not in this one. So these are the boundaries of the axilla, right? Superiorly and laterally it's the axillary vein, anteriorly pectoralis muscles, medially serratus anterior, laterally don't go beyond the anterior margin of the latissimus dorsi, posteriorly only the subscapularis. And we need to address these 3 levels. So 1, lateral to the pectoralis minor muscle, 2, between the lateral and medial borders of pectoralis minor, both in front and behind. And level 3 is medial to the pectoralis minor, and the Halsted ligament, that is a costoclavicular ligament out there. Now the steps, I don't think I should be going into this because we need to remove all the fat, areolar tissue and lymph nodes in the axilla, right? Now certain things need to be taken care of. For example, don't bare the axillary vein too much. There has to be a fascia covering the axillary vein which needs to be preserved, and the pectoralis major is retracted, and then you will also have to retract the pectoralis minor to go behind it, remove the nodes both in front of the minor and also behind the minor. And in case you want to do level 3, then again you have to firmly retract pectoralis major upwards, bring down the pectoralis minor or put in a sling around the pectoralis minor, and then go to level 3. And some people, they also split the pectoralis major between the sternal head and the clavicular head. By that, making a split out there, you retract and you get direct access to the level 3. And regarding this, the second and third intercostobrachial nerve traverses the axillary space perpendicular to the latissimus dorsi and the chest wall. They may be preserved if it is not involved by the tumor. Yes, so here is the anatomy out there. We have to make sure that we don't remove more lymph nodes than is necessary. So there is a certain area you're not supposed to go beyond that. Here you can see the vein is not here. Anyway, there is a lateral axillary vein which comes down sort of parallel to the vessel supplying the latissimus dorsi. So most of the axillary lymph nodes are found medial to this lateral axillary nerve, lateral axillary vein. And 90% of the lymph nodes are there here. So you will rarely have to go lateral to it, right? And because we are always afraid of, in the post-operative period, this edema of the arm, there's something very little we can do about. So the best way to do is try and prevent it as much as possible. Make sure that you have taken care of hemostasis. Suction drains are placed in the axilla. One in the axilla, and make sure that it's not very close to the axillary vein, and another beneath the flaps, that is the upper or the lower flap, and the wound is closed. Now come down to the complications. So hematoma is possibly the most common complication, and consequence, high volume sanguineous drain output, skin flap elevation and skin ecchymosis. This is what you see. And management, small hematomas don't really have to do anything. Large hematomas, you may have active bleeding, significant oozing, and so you may have to explore. Next complication, wound infection. Not much of a problem in most cases. There may be wound dehiscence, foul smell, and of course you must be using preoperative prophylactic antibiotics. Seroma, fullness at the surgical site, elevated skin flap, persistent seroma leading to infections. The problem is the patient may present with this after discharge. So you may not be seeing it in the first 1 or 2 weeks of surgery. The patient may come to you later in the outdoor with the swelling out there. And mostly it can be managed by needle aspiration. And in certain cases, if it is persistent, you may have to leave behind a catheter. Skin flap necrosis, as I was telling you, the best way to tackle it is by preventing it. Make sure that you have an optimum thickness in the flaps that you leave behind. And at the end of the operation, you may excise, say, about 2 to 3 millimeter of margin on either flaps, just to make sure that there is good bleeding. And in case it has taken place, well, you don't have much to do other than to excise the gangrenous part. And so you will be having a loss of skin flap, wound dehiscence will be there, regular dressing, debridement, negative pressure wound therapy, these things are going to help. And don't forget, the patient is losing time with flap necrosis because the adjuvant treatment gets delayed. So try and prevent it as much as possible. Lymphedema, the most dreaded thing. Again, as I said, it is best managed by prevention, right when you are doing the dissection. So you should stay between that small area from the margin of the pectoralis major. You come laterally. Don't go beyond the vein I was talking about, the lateral thoracic vein, and below down you will find another vein, which is called namta bhule jachi. Anyway, angular vein, yes, angular vein. Top it is the lateral axillary vein, and beneath it is the angular vein. And this is actually a vein which communicates between the scapular plexus and the neurovascular bundle which is supplying the latissimus dorsi. So swelling of the ipsilateral arm, heaviness, restriction of movement, this is the consequence. And as I said, you need to prevent them mostly. And nowadays, yes, people are doing lots of things regarding, they are doing lymphovenous anastomosis and all that. But then again, that is beyond the scope of general surgeons. It is a microvascular procedure, and still I think it is in the experimental stage. And when you have lymphedema, as we do it in other lymphedemas, mainly in the inferior extremity, you can call in your plastic surgeon colleague to get these things done, Thompson's skin flap raised, tissue removed and skin closed, Charles tissue resection, or Homan's wedge resection, and things like that. So anyway, it is a progressive condition. That is something you need to know. It is not going to go away. Complications associated with nerve injury. So intercostal brachial nerve, yes, 1 or 2, if it is going through the tumor or it is going through the involved lymph nodes, you can excise. It will give rise to numbness in the medial aspect of the upper arm. Nothing much to worry about. It will be a nagging problem with the patient, which is going to improve with time. Long thoracic nerve, medial and lateral pectoral nerve, thoracodorsal nerve, these nerves you have to preserve. There is, no way you can compromise with these. So it will give rise to these problems, as you can see. Paralysis of the serratus anterior muscle giving rise to wing scapula. Median and lateral pectoral nerves, the pectoral muscles are going to atrophy. Thoracodorsal nerve, so paralysis of latissimus dorsi muscle, internal rotation and abduction of the muscle is weakened. Not only that, later on you will not be able to use this muscle for any kind of mammoplasty. So that is another big problem. So nerve injuries prevented by properly identifying the structures, leaving the fascia above them intact, and avoiding excessive retraction and shoulder manipulation during surgery is very important. So that's all. Thank you. Gradually, as days go by, we have to make sure that we should be rarely performing this surgery. We have to get hold of patients in the early stage and maybe perform surgeries which were shown earlier. Thank you.
Any questions? Okay, then thank you, Professor. Thank you. Next is Dr. Pathology Ghosh, excision of impalpable lesion.
Actually, Partho should have started this program first. They will create the defect, and then Amit will come and close the defect. But he has done it first. So you create the both, no? Same time. Okay.
ওখানে জায়গা নেই ঠিক আছে থ্যাংক ইউ হ্যাঁ ফার্স্ট এটা It's okay. Actually, one information is missing. That I did my postgraduate under SAR, and I was the first postgraduate under him. When he came back to RG Kor Medical College, I was the first postgraduate. He was my guide. He is my guide. He will remain my guide until time permits. So, with these few words, we have already, Professor Amit Rai already has discussed about the BCS. SAR has discussed mastectomy. But everywhere, whatever surgery you do, one thing is the cornerstone of success, that is the margin. So the debate, which started many years back, still remains that what should be the margin. And it has undergone a lot of changes over time. And at present, we all know that there is no tumor on the ink margin. So that is the concept in case of invasive breast carcinoma, and for DCIS, we require a 2 millimeter margin. Now, how to achieve this margin, especially in cases of BCS? Of course, we always try to remain 1 centimeter away from the tumor, but it's a macroscopic, macroscopic approach. But when our pathologist colleagues see it under microscope, it may become positive. So we generally do two things. Number one, we put clips. It not only guides the radiotherapist person to give radiotherapy in the proper place. It's not only that. At the same time, if you require a redesection, you have to target the clips once again. But of course, the 3D perception is lost because the cavity is already obliterated. The second thing is that you have to wait for the frozen section biopsy of the margin, but it's not very practical, and once again, it's not widely available for us. So, to solve this problem, so the challenges, what I have already mentioned, that positive margins occur in 20 to 40% of cases, leading to re-excision. So, the approach is to cavity severing. What I am going to discuss first is actually to reduce the reoperation risk. This was the trial which has shown that BCT is equivalent to mastectomy. Now, this is actually the recent statement of the guidelines regarding the margin. I want to read out that what do we mean by a positive margin, that defined as ink on invasive cancer or ductal carcinoma in situ is associated with at least twofold increase in inter-best recurrence. So that is important, and most important is that this increased risk of recurrence is not nullified by delivery of a boost dose of radiation, number one, delivery of systemic therapy, and favorable biology. So nothing is going to reduce the risk of a positive margin. That is the most important of this statement, number one. Negative margins, knowing the routine practice to obtain wider negative margin widths has no ink on tumor is not indicated. So there is no benefit if you want to get more margin. Systemic therapy, The rates of IVT are reduced with use of systemic therapy. It's uncommon circumstances, patient not receiving adjuvant systemic therapy. There is no evidence suggesting that margins wider than knowing tumor is needed. Biologic subtypes, radiation therapy I have already mentioned, invasive. Now the young age, once again, and extension intraductal component. This, in these cases, have a large residual DCIS burden after lumpectomy. There is no evidence of association between increased IVT and EIC when margins are negative. So our target is to achieve a negative margin. That is important. Now, how cavity saving helps? Cavity saving, the definition is that, the concept is that you remove the tumor with 1 centimeter margin. The surgeon removes the tumor with 1 centimeter margin. After that, you systematically remove all the walls of the cavity with few millimeter, 5 millimeters, suppose, a 5 millimeter rim from all the margins. There are at least 6 margins, one superior, inferior, medial, lateral, below and above, when the tumor is at least 1 centimeter away from the skin. If you don't have, if it is towards the skin, less than 1 centimeter from the skin, we have to include the skin as well. So after removing this, you have to do that. But where remains the problem? Professor Amit Rai was trying to tell, it depends on the volume, what is the cosmetic outcome of the patient. So of course, mandatorily, you are removing a more amount of tissue from the breast with this approach. So this is the rationale that you don't need re-excision of the same pathology, because it increases the anxiety of the patient, cost, delay in adjuvant therapy, which is very important. Poor cosmetic outcome, when you reoperate on the patient, the cosmetic outcome is poorer. Conversion to mastectomy. So these are the problems with that. So this is how we send the specimens after removing 0.5 centimeter of tissue all around. Now, to address the problem of cosmetic problems after routine cavity saving, this is the key study which has changed our mind actually. By Shabgar, what they did, if you see that the pink one is the original tumor, and the initial resection with 1 centimeter of margin. They did a RCT of this. What they did, they removed, the surgeon came and they removed the tumor with a 1 centimeter of margin. After that, the surgeon thinks, it commonly happens that probably the medial margin is not adequate. So the next border on the medial aspect is to remove some more amount of tissue as per the choice of the surgeon. Till the surgeon doesn't know in this randomization that whether this patient is for cavity saving or not for cavity saving. Then the box is open, whether the patient will go for cavity saving or not for cavity saving. If the patient is the candidate for cavity saving, then 0.5, 0.5, 0.56 margins are taken and sent separately for biopsy. If the patient is not for cavity saving, the operation ends there. And if you come to the conclusion, we found that the cavity saving resulted in halving the rates of positive margins and reoperation. And they have shown that there is no problem or no difference in cosmetic outcome. So this SAVE trial is the only RCT present nowadays, but probably cavity saving, there are some prospective studies regarding this. I'm not going into details of that, but probably it can change the practice in future because it's a fantastic trial. Special populations where benefit is more, number one, if it is a DCIS, if it is a dense breast, because understanding of the end of the tumor becomes difficult on those cases, lobular carcinoma. And of course, it is less benefits with small tumors with wide margins already taken, and elderly with comorbidities. It's not required. Oncologic outcome, no change in the overall survival or recurrence. It has been shown lower excision rate, higher patient satisfaction, and reduced stress and cost on the patient. Cosmetic outcome satisfactory, I've already mentioned. Now the controversies. Not universally accepted because there is a single RCT at present. Concerns are operative time, cost, and unnecessary tissue removal. Need standardized margin evaluation. So, as per the recent guideline in 2021, it's not routinely mandated, should be considered in high-risk patient, and you should be individualized in which case you are going to do. So the concept of cavity saving, which was there in frozen section biopsy, can be a routine cavity saving after removal of the tumor. This is where the concept of cavity saving stands today. Thank you. I'm going for my next presentation.
Thank you, Professor Ghosh, for your excellent presentation.
আরেকটা আছে না না এটা এই প্রেজেন্টেশন আরেকটা প্রেজেন্টেশন আছে হ্যাঁ now the second impalpable lesions. So this is once again a very not commonly practiced zone for all of us, but remains a real problem for all of us when it is visible in image but not appreciated by the clinician. So it requires management which entirely depends on the, even when you are going for a lumpectomy, the tactile sensation of the surgeon, the tactile sensation for the surgeon is the key by means of which actually you take a 1 centimeter margin. But when you cannot palpate it, then you have to depend on the radiologist. These are the areas where is actually when it is required before any upfront surgery, after post NSCT, as Professor Chatterjee has already mentioned, and in case of axilla, he yesterday mentioned that mandatorily the first tier of lymph nodes comes under so it can get vanished. So or it can be vanished after after NSCT, so it's required. Once again, the accurate localization is important for two issues. There is a balance actually. If you know that it is in the upper outer quadrant, if you don't locate it and try to excise it, you will excise too much, so poor cosmesis. On the other side, if you go for a little excision, the margin will become positive. So localization becomes important, and this is how it has developed in last 30 years. I will come to that one by one. So, of course, in detection of impalpable lesion it's actually an uneasy partnership between the radiologist and the surgeon. We already have experienced this. Most important, which is widely available and most commonly practiced in this part of the world, is the hook and wire localization. It is done under local anesthesia by the radiologist. The key words are on the same day as the patient's planned surgery and after performing under ultrasound guidance. The advantage is that it can be done under ultrasound guidance. It can be done under mammography, because suppose a calcification, not well seen under ultrasound guidance. So procedures which can be done under all the guidance is most important, number 2. And surgery followed by specimen radiography. So it can also be done. So you take the patient to the radiology department, you place the wire, you bring back the patient to the OT, and you operate and take the specimen once again to the radiology department. So this is the entire plan, and you have to do that. And this is not a good experience, not only in our part of the planet, it's everywhere. In every study, in every literature, it is mentioned that this scheduling is not at all easy. I'm not going into the details. Some tips. when you are localizing the tumor. Number one, where must be placed close to the surgical incision. It should not be away from the surgical incision, number one. The skin puncture site must be discussed with the surgeon. Always it is better if the surgeon remains there. The wear must follow the shortest perpendicular path to the lesion. That is very important, otherwise sometimes it is very difficult to appreciate. The tip of the puncture site length should be minimum, and another important issue is that the wear should not be up to the center of the tumor. It must cross the tumor, so that entire tumor is actually behind the tip of the wear or the hook. That is very important, otherwise it's very difficult. So first of all, you need to localize the tumor. I think you can recapitulate yesterday how a malignant lesion looks like. Then after local anesthesia, there is a needle-like thing which is hollow, which is taken to the center of the lesion. You can, I don't know whether you will be able to appreciate, it is reaching up to the center. It is going to the inside the tumor. And after doing that, when it reaches the area, then you have to insert the wire. Yeah, that is one of the problems. I will mention that. The patient feels pain. It's not at all comfortable for the patient. And we will talk about the other investigations. The world, when it is developing, people are trying to address all these issues. And two important issues. One is the patient comfort. One, the scheduling, which is not directly a medical problem, but the main cause of development of this, coming out of this new techniques is actually to address scheduling and patient discomfort. In all the cases, the patient actually screams. I have stopped the audio for that reason, but that is one of the major problems. So after localization, you have to put the incision, keeping the wire in the center. And then, keeping the wire in the center, you have to excise the lesion. After excision, the right side shows the left over cavity. You repair it, and that is the specimen. So this is how wire localization is done, and the non-palpable lesion is excised. Now, US guided clip placement inside the axilla. The technique remains same once again. Under ultrasound guidance, you have to put the needle at the center of the lymph node. I think you can see the fire of the clip. The clip has been fired at the center. And of course, that picture shows the presence of clip inside the lymph node. Now, intraoperative ultrasound. This is something can be done at the same place. Patient may remain awake when you are initially locating it, no pain. This is when done in a semi-palpable, a semi-palpable lesion, not well palpable. It can be easily repeated. You have to locate at its closest point through which you want to approach it, the length, breadth. Of course, it is sometimes difficult if it is very small and it is deeply placed. in a huge breast, intraoperative ultrasound is difficult. Otherwise, it addresses other problems of scheduling and patient discomfort. This is the specimen ultrasound that, again, you need not to take it to the radiology department, can be done inside the OT just after surgery, after leaving the cavity behind. These are the advantages of intraoperative ultrasound, that direct visualization during surgery, no need to depend on other specialties, patient-friendly, no prick, can be repeated, can be done in awake patients, specimen mammography done in the operating room, and no need for multiple procedures or scheduling issues. Disadvantage, it requires training. You have to take training. You have to take training to identify the lesion. It's not very simple. Smaller and deep lesions are missed. But to avoid that, there are technologies. One is this hydrogel capsules, which are not detected. You can take the patient to mammo. In ultrasound, take for mammo, place the hydrogel at the center. Now that hydrogel can be detected at OT, and you can remove the lesion. Learning curve, it's not that difficult. It has been seen in one study that 7 to 17, average of 11 cases, after 11 cases, you can use it with success. Seed localization, where there is always a chance of displacement. Yesterday, after the, now it is associated with a hook, but simple where it almost always get displaced during the movement of the patient, especially if not done on the same day. So seeds are devoid of that. So the radioactive techniques, there are a few techniques, we don't do it, but just for discussion. Number one, you can give just simple radioactive tracer injection inside the, inside the tumor. But the advantage is that the sentinel lymph node sometime also it also go to the sentinel lymph node. So at the same time, you can address both the lesion. So this is the advantage of a free radiotracer injection inside the tumor. And you detect it by gamma probe. And there are other where the iodine, radioactive iodine, is placed inside a capsule, and the capsule is placed inside. So there is no free, so you cannot detect the center. So this is by radioactive techniques. One important issue in this radioactive technique, there is no sound, but I just want to say, if you directly place on the radio tracer, the sound is it indicates that you are just perpendicularly above. If there is any angulation, the frequency of sound becomes less. Tick, 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 tick. So actually it guides the surgeons very well. So this is a very good technology of having a radio tracer. Also, it is by the number. Less number means more accurate. There are problems, once again, with radioactivity like this. So scheduling issues are once again there, because it will disappear if it is a free tracer injection, not a capsule. Magnetic techniques. Magnetic seed and magnetic probe. The seed is not itself is not a magnet. The probe actually turns the seed into a magnet and detects its presence. Most important problem with this magnetic seed, if you it's an MRI detected tumor, if you want to perform an MRI, it will create a big artifact. Radar techniques, just simple technology, just what we use in radar. The radio waves released from an antenna, go to that, detects the plane, get back to the one another antenna. This is the concept. Same is used. One of the technologies is Civic Scout. I'm not going into detail of this, but there is a potential of interference with the operating lights. But they remain for a long, long time, all these technologies. This is once again a radio frequency based technique, localizer is most popular. Carbon, it is not a recent technique, it was an older technique if you follow that. Just to mention, carbon don't dissolve, it's just like tattooing. So you go to the tumor, important, but good in is this, you go to the tumor, you inject the carbon, and when you get back, taking out the needle, you go on injecting this. So the path is marked, and it will remain, it will never dissolve. So that is the advantage of carbon technique. Now, the comparison between all these techniques. If you notice that the positive margin and reoperation rates are best with intraoperative ultrasound and cavis scout. So that means the radar system. So these are the best outcomes. So not this part of the world, though the world moves as a single unit, but the science not. The other part of the world is moving away from the world localization, but for us in this part of the world, of course, we have to master the world localization. Shift from invasive to the conclusion. In conclusion, the evolution of this localization I have already mentioned, that it shifts from the invasive and uncomfortable procedure to less invasive and more patient-friendly techniques. That is the cause of evolution. Address the scheduling issues. Each method has its own advantage and limitations, and the choice of method should be individualized based on the characteristic of the lesion and the resources available and patient's preference. And there is still a lot of scope for improvement and innovation. Thank you.
Can I? So thank you very much, Professor Ghosh. So as a very good topic, and most of the time, most of the books, I have not gone through this literature. Most of the books, they are advocating the well localization.
Yes,
And
sir.
can we do it in the OT? Because when we are transferring the patient from the radiology department to the OT, there may be possibility of displacement or even fracture of the wear.
That is the biggest problem actually.
So
the
can we
radio-
do it in the OT?
Yeah, why not?
Yeah.
You need a, sir, if we are going for an
Ultrasound
intraoperative
is a-
ultrasound, then actually in most of the cases you don't require the VAT to be placed. That is
And
the-
because you are doing specimen mammography.
Yes, sir.
Um,
Yeah. Yes, sir. Now, even
And I think
in
that
many
should
of
be
our
done.
institutions, we are asking for an ultrasound in the OT. Then also, while localization is not mandatory always.
Now, any question on the?
Even if you do have an introp ultrasound, I'm not saying that, Sophie sir, I'm not saying that we can do away with the wire-guided localization. The wire, the issues, the logistic issues that we are talking about, that is the scheduling and all that, that can be overcome. So even if you are seeing an introp, the route, the track, no, that can be done in OT. That is not an issue. I am just addressing Partho's concern that can we do away with the wire if we have an introp ultrasound. Introp ultrasound will tell you, but you cannot make your incision and do a constant introp monitoring.
No.
Yeah.
I
So
am
that-
telling you one
yeah.
thing, that what I tried to mention in my conclusion slide, that there is a lot of scope for
There
all
is,
of
there
us.
is, definitely.
Just think, if you have an ultrasound, you take a spinal needle,
Yes,
you localize
you
it,
need not
you
use a
place
wire.
it, madam,
Yeah,
you put methylene dye, you try to, use the concept of carbon technology, you take it out. You
So
follow
the
that
same way
track,
that we
you
do a
can reach.
sentinel
So
using methylene blue, the
yes,
same policy.
At the same time, you will get the sentinel.
Right.
So simple concept can the purpose of this presentation is that every technology has its own advantages and disadvantages. There are simple measures that you can adapt to get the advantage of this all the technologies. Yes, sir.
So the other,
Yes, sir.
jugaad that we have done is, so when the radiologist does the wire localization, we ask them to make a diagram Because see, we are seeing the needle coming like this. How deep is it going? They should have a note that it is going at a depth of say 4 cm. They don't give you a diagram, sir. So we can see the needle. So now what we are doing is we request them to make a diagram that is going in through 1 o'clock. Till what depth is it going? These orientations are also required. And if possible, they share a small. Now with WhatsApp, you know what they do is they share the same video that you were showing of the wire going in. So when we are starting the OT, we just see that this little video that they share with us. So we know exactly what is the direction of the needle, how deep it is going. That helps. But yes, if you have an intraoperative ultrasound, life is much, much safer. That's the best. That's the best. Yeah. Yes, definitely, sir.
Yes, sir. As I am a urologist, ma'am, nowadays for PCNL, initially we are doing in fluoroscopy.
Right.
So much of radiation hazard and all these things, we have to make the patient prone. Now, ultrasound in OT comes is a very big way.
Absolutely, absolutely.
Very big way. Now, we all are trained to do initial puncture in supine with ultrasound guidance. We are targeting the stone, we are going there, just dilating it. It's very easy, just matter of training, sir, as you told.
Yeah.
So it is a
very
new
Probably it
skill
will
that
be
all
in
surgeons
future
have
it
to
will be,
incorporate in
yes,
their
yes.
armamentarium.
Probably it will be
Getting
incorporated
Ultrasound is the
in the
basic
surgical
armamentarium
training.
in
Yes,
OT.
absolutely, absolutely.
Because it is not only that, it's a simple extension of the clinical examination
Exactly.
as well.
It's like the stethoscope of a surgeon.
Yeah.
It's a
It
stethoscope
will just
of a
replace
surgeon.
the stethoscope for a surgeon.
Right.
It is simple. Yeah.
Yes, you can.
You can
You-
go
you
the
can.
that I mentioned that specimen mammography. You can do it. If you are in doubt, you can just round the probe and you can see whether there is any suspicious lesion near the margin. So there is a lot.
We haven't, achieved the skills to that level yet. Yeah.
Initially showed us that a laparoscopy can be done. Now they have also taken the lead by using the ultrasound first. They are the first clinicians to be using ultrasound in their chamber.
Yeah. They are routinely doing. The gynecologists are routinely assessing the.
Not only that, nowadays their reports are accepted in court. Previously it was a time that without a literatus report it was not good. But now obstetrician's report regarding the fetal-placental profile is highly acceptable in court. And so that is why we should learn from them that nowadays, from now on, we should be keeping an ultrasound machine not only in the OT, in the OPD also.
Okay. Ultrasound is an integral part of clinical medicine, if I may say. Absolutely, all clinicians like that. It was the stethoscope. Now it is the ultrasound, at least level 1, and if possible level 2 at least, everybody should be able to.
It's a handheld, just looks as big as the mobile. Okay?
Actually-
and there is a software in it. So there is a small probe separate, and you have an ultrasound machine which looks like this, which just looks at the interface is like your mobile. So you put the probe, and the software is going to track the image. You can capture the image as well. So it is obviously still new.
No, this
but
is
that
under
is-
trial.
This is under trial, yeah, that's what I'm saying. But that is the future. You will
Yeah.
not have a big machine.
World Health
you will have a soft
Organization
portable
is
one.
what Shomita Di is mentioning. World Health Organization is, is organizing this trial.
Actually, Partho is
I
part
am
of
a
that
one.
trial. Yes,
I'm
Partho is
part of
the
that trial. By a handheld, you can
Handheld
identify.
portable.
It can be used by the surgeons, by others, so that you can pick up lesions. It looks.
No. That's a different one. This one, the WHO has started mainly for even remote breast
Examination.
finding out breast
It's very
examination.
simple.
So if you are in a
It's a
remotely
very
placed,
nice
you can see it.
instrument,
You
just
can
like
send me the
Eitubu,
image.
chuttu.
I can guide you
Just
as to
you
what
can
to
use
do.
like
That's
this.
the plan.
Oh. But there is a big licensing issue, sir.
Yes.
That is the. Sir.
Yes, you should not be using it
For any other
gender
purpose.
and other things. Yes.
So it's.
PCP
No.
people,
So
yeah.
that is
PCP
why it is
people.
not available or in
So it is
India.
only in the trial
That is the
phase at the
reason.
moment. Yeah.
So very good discussion. Let us stop here. And we have with us our Vice Chancellor, Professor Sudipto Bose. So, and he has given his comment. So let us proceed on to the next session.
Thank
But
you so
that's
much,
he
sir.
He has come.
Thank you so much, sir. I now request Professor Hiranmay Bhattacharya, sir, to please hand over the certificate to Amit Roy, sir. Thank you so much, sir. I now request Professor Sudipta Bose, sir, to please hand over the certificate to Professor Hiranmay Bhattacharya, sir, and Professor Bharat, sir, respectively. Thank you so much, sir. Up next is the time for poster and paper presentation by residents. I would request Sharad sir to take charge and conduct the session.
Hello. Okay. So now is the time for poster and paper presentation, and we'll be starting one by one, and I'll be calling. You have 2 minutes to tell the summary of your poster, and then 2 minutes for viva. So first, is Dr. Aman Goel present? No. Okay. Dr. Gaurav Kumar. Absent, yes, ma'am. Yes, I have already told you. Just a summary of what is your case, and then
Good morning, everyone. Honorable Vice Chancellor, sir, respected member of the jury, teachers, and my dear colleagues. Today, I, Dr. Gaurav Kumar from Ortho Department, is going to present the poster on the topic giant cell tumor of metatarsal in a 10-year-old boy. Giant cell tumors are very rare in the pediatric population, and its incidence is only 1 to 8 to 7.5%. Our case report is a 10-year-old boy who presented with swelling of the foot, that is the metatarsal bone, which was size of 2 into 1.5 into 1 centimeter. There were no sign of local infection. All the routine investigation, including the blood, radio and histopathological examination was done. He was managed with a reconstructive surgery with local resection of the tumor and replacement with the ipsilateral fibular strut graft, and was fixed with a K-wire. Although these lesions are not malignant and frequently can be managed satisfactorily with the intralesional procedure, but local resection of the affected metatarsal with autograft or allograft is preferred. Now at last I would like to conclude that this case, in spite of its location, skeletal maturity and radiograph, the diagnosis of giant cell tumor should be made final only after the histopathological study and one should always keep the giant cell tumor as a differential diagnosis. Since it's a pediatric population, it's not very common. In the pediatric population, the osteochondroma or Ewing sarcoma are common. Thank you.
Thank you, Dr. Gaurav. You said that in your case, the diagnosis was a giant cell tumor. Osteochondroma is common, but Ewing's in the foot metatarsal bones is not common, which is the other common bone tumor that you will get in the foot metatarsals. You can, in your DD, you also have to keep aneurysmal bone cysts in mind,
Yes, yes.
right?
Aneurysmal bone cyst is
cysts in
common.
mind. Second thing I wanted to know, you did a fibular allograft, right? What are the alternative reconstruction options that you can offer to this patient?
Ma'am, we can use bone cement that we can put.
Bone cement cannot be a filler for the whole thing because you have excised the whole metatarsal. You will also have to excise the surrounding soft tissue and the ligaments, right? So bone cement cannot be an option. So what, anything
Ma'am,
else?
since fibula bears only 15% of the body weight and tibia bears 85% of the body weight, so it is best option available.
Yes, fibula is a good option. If you somehow cannot do it, another good option is silicone implants, right? So they can be given because it's a pediatric patient, once they grow, these implants can be changed at a later date, right? Yes, and percentage you said is what, how much? 1.8
to 7.5%.
So what is your follow-up protocol for this child?
Ma'am, the child will follow regular follow-up. We have done the regular X-rays we have taken.
No, be more precise. When
Ma'am,
when
3
you say
months
regular,
and 6 months follow-up. Child was able to bear weight and no post-operative pain was there.
how far have you followed up the child?
Ma'am, till 1 year.
Till 1 year.
Yes.
And what is your advice for the parents?
Ma'am, he advised special footwear so that he should not get other infection post-op and all that.
That is not the point. When I say advice for the patients is for the follow-up of the child, because they have to be kept under surveillance. It is a localized malignancy. They do not have generalized spread. But yes, there can be local recurrence.
Malignant
as well.
transformation is also very rare.
Yes, but they can have local recurrence. So the child, I mean, the parents have to be told if there's any swelling, even mild pain. They don't require footwear. You've just replaced a metatarsal. It's not a weight-bearing area. So, but coming for a regular follow-up and being, counseling that.
If any sign of inflammation or any
Yes,
swelling is
yes.
present, then they will follow.
Right.
The marrow cavity of the first metatarsal. Is it normal?
Sir, it's slight widened.
And did you notice it?
Yes.
The child will grow. What about the fibular allograft? Is there any disparity? How will you manage that? Okay. So the HP report confirms your diagnosis of GCT. The histopathological report.
Yes.
You have put a slide
Yes.
on the lower corner. Does it confirms your diagnosis of GCT?
It shows mononuclear cells
Yes.
and multinuclear giant cells. Sir.
So it confirms.
Confirmation is by both radiological in classical soap bubble appearance scenes and histopathological also.
No. You haven't mentioned the histopathological report
Okay.
in
And I think
your presentation. That's why I am asking.
What's taking sir's points, you should also be aware of the other giant cell lesions of the bone. So, something else also.
This is a message for the others as well. So when you make posters, posters is a visual media, right? So your images should be larger in size. You know, your writing can be lesser or even smaller, but I would have appreciated if your X-ray and your histopath slides, you know, the images were better. It would have been easier for us. So for your next poster, just concentrate on the images.
And one clinical photograph should have been
Yes,
placed.
totally true, totally true. Yeah.
Okay, thank you, sir.
Thank you, Gaurav. Next, do we have Dr. Gurveer Singh? No. Dr. Kavita Gupta? No. Dr. Mohammad Hassan, please. Shuman, your key laptop na. Na key hoy. Cross key kore hoya. Cross karo. Yes. He also not there, sir. Hassan. Yes, ma'am.
What we were telling you in the previous poster, the same thing is here also. You can see, I mean, is it possible to read the scans you have placed there? Okay.
Yes, ma'am. Good morning, everybody. My poster is on disseminated hydatidosis. Disseminated hydatidosis is a rare manifestation of hydatid disease caused primarily by Echinococcus granulosus. It involves widespread cystic lesion across multiple organs. Primarily, it affects the liver and lungs. Case report: a 33-year-old female presented to surgery OPD of our institution with complaint of abdominal pain, abdominal mass from the last 3 months, and abdominal pain from the last 1 month. On examination, multiple cystic lesion found all over the abdomen. An investigation was done, blood investigation and serology was done, which confirms the diagnosis of hydatid cyst. And USG and CCT abdomen suggested disseminated hydatidosis. Surgical procedure, exploratory laparotomy and hydatid cystectomy was done. Post-operative period was uneventful and antiparasitic regimen was started and patient was discharged. Discussion. Disseminated hydatidosis represents a complex and rare manifestation of hydatid disease. Unlike localized hydatidosis, the disseminated form results from systemic spread, often via hematogenous or peritoneal, leading to complex diagnostic and therapeutic challenges. Diagnosis hinges on imaging and serology, while management requires multidisciplinary and case-specific approach. Conclusion is disseminated hydatidosis, a rare manifestation of hydatid disease, needs proper evaluation and insight into unusual presentation, imaging characteristic, and evolving surgical and medical strategies. Most often, it is secondary to rupture or surgical spillage from primary cyst, that is from liver or lungs. Diagnosis is primarily based on imaging and serological test. Medical therapy is the mainstay for disseminated disease, with surgery reserved for complicated diseases.
Shall I take it, sir? Okay, yeah. So, Dr. Hassan, your patient was primarily diagnosed as multiple hydatidosis, right? So when you said blood investigations were done, what blood investigation? I'm not talking about the hemoglobin TCDC.
Yes,
was any specific blood investigation done which diagnosed it? Yes.
Serology.
What
Immunoglobulin
serology?
IgG.
IgG, what? Be very specific.
ELISA.
ELISA is a method.
Method.
Yeah. What did you do? You have to be a little specific.
IgG for antibody.
Of antibody against what? So against what is the organism?
Against the organism, Echinococcus
so
granulosus.
yes, so it has to be an IgG, Echinococcus granulosus. That is what you have to do, number one. Number two, because it is a generalized disease, did you give him any pharmacotherapy before you planned him for surgery?
No, ma'am.
So that is what is to be done. So you have said that the medical treatment is a mainstay. The mainstay has to come first. Surgery comes in only if it is a mass effect or, patient is sick and all that. So how, if I were to tell you that you give him albendazole, how much would you give him and how long would you give him?
And generally, in disseminated 400 milligram BD is given for 2 to 3 months with a period gap of 15 days. In between.
Gap of 15 days between?
Between the cycle, 2 to 3 cycle of 28 days to 30.
Okay, so it's not 15 days, it's a 1 week gap.
Yes.
But the point is, why do we give that gap?
Ma'am, hepatotoxicity due to albendazole, hepatotoxicity.
That is not the cause. There is something else that albendazole does. So it causes platelet suppression.
Platelets, yeah, bone marrow suppression.
Not bone marrow. Don't mix up things.
Yes.
It's platelet. Platelet and bone marrow are not equivalent, right? So yes, that's why you say you give it for 3 weeks, then a 7-day gap, and then you again start it for 3 weeks, and then. So yeah, at least 3 cycles.
3 cycles.
But if the patient's symptoms are florid, you cannot, at least 1 month should be given. What about post-op? Post-op also you have to continue patients with. Yeah, Amita?
On investigation, you have done the CECT.
Yes.
There are classifications of CT finding in hydatidosis.
Yes, sir.
You haven't mentioned. So what are the classifications? In your case, is it 3, 4, 5? You know the classification?
Sir, Garvey.
C classification.
C classification. Garvey classification, sir.
How the classification helps?
Management is according to the classification. You don't need to do surgery in all cases.
Yes, sir.
Management depends upon the classification. That's why mention of the classification is important, number 1. And number 2, you have written the references, but it is not in a proper way. So what is the proper way of mentioning the references? Do you know Vancouver style?
No, sir.
Okay.
Dr. Hassan, I have a question. I remember this case coming to us for pathology, histopathology, but there was no mention of histopathology in your case presentation. So, I mean, any reason for that? Because once you have removed the tissue, you have done a cystectomy, your case is not complete unless you do a histopathology. And the same case had come to our department for histopathology. There were beautiful pictures of histopathology also. When you're presenting a case, I think you should have included that.
Next, Dr. Piyush Anand. Absent, ma'am.
बहुत लंबा कर दिया सर। सर ठीक।
Good morning, dear professors and jury members. I, Piyush Anand, am going to present a poster on amniotic membrane as an effective biological dressing in burn patients and patients requiring skin grafts. It is a biological dressing which is used for burn wounds, and it is effective and cheap. It is easily available, and so it is transparent and semi-membranous. And the aim of this study was to compare it with paraffin gauze dressing, which we used in which we use in burn dressings and patients requiring skin grafts. So, the study population were for a duration of 6 months. Patients were admitted in our department. Patients who had burn injuries and they required skin grafting. And sir, and this amniotic membrane was was preserved in a solution of normal saline, and it was then stored in a container which with antibiotic solutions and antifungal agents, and it was stored in a refrigerator, and the expiry date was around it was marked properly, dated, and around 7 days it was the expiry date for that, and the results were quite positive, sir. The average healing time was reduced. The days required between consecutive dressings were increased, sir, and the graft bed was prepared better as compared to paraffin gauze dressings. And patient satisfaction was also better, sir, and side effects were also less. Thank you.
Dr. Piyush, so this was your thesis topic?
No, sir.
Okay.
No,
So,
ma'am.
but you said that the population, so how many patients did you have in your study?
Ma'am, around 30 to 35 patients were.
But I don't see that written anywhere.
Sorry, ma'am.
Is it? Or
Yes,
can you just blow it up there, please?
Yes, ma'am.
Yeah.
It is written here.
Okay, sample size is there, na? Sorry,
Yes, ma'am.
I couldn't see it, sorry. So of those 30 odd, can we have the poster back on the screen, please? Yeah. So of the 30 odd patients, how many did you find a graft loss? Of the amniotic graft loss, obviously.
Means if we compare per 10, if we compare, then out of 10 patients, I think 2 or 3 patients had a graft loss.
See, when you present data, your data has to be very precise. So it cannot be approx. I studied 30 patients, of whom so many healed, so many didn't heal, so many there was a loss. That's how your presentation has to go. Okay. Secondly, you said you've compared it to paraffin gauze. Now, paraffin gauze is just a dressing module. If you have to at all compare it, it has to be compared with a graft, okay, or a skin graft. So you really cannot compare paraffin. The only thing you can say is that the duration in which it heals, whether that is being cut forward, I think that is what you saw.
Yes,
Third, how did you source these placental?
From the gynae department.
So do you retrieve it? Do they
No, sir.
retrieve it?
No.
Because the retrieval itself is a very specific.
They retrieve it, ma'am. They retrieve it and store it in the.
And you access it
yes,
from
ma'am.
there.
Yes,
okay. And of the patients in whom you did use it, what was the extent of burns in these patients? Were they small localized burns? Were they extensive burns? Because you cannot get so much of amniotic membrane for
No, ma'am,
dressing.
small localized burns,
so do
not
you have
extensive.
the data on what was the average percentage of burns in your patients?
Average around 10%.
So I would suggest, you add these in your information when you present this again. Okay, thank you.
And also the degree of the burn. So you use this amniotic membrane graft in all degrees of burn, or in superficial second degree, or
superficial second degree burn.
Superficial
Yes,
second
yes,
degree.
sir.
And whatever the first degree burn, you omitted that?
Yes, data was not there.
Before you dressed it with the amniotic membrane, did you have a wound swab or something, like we do in a skin graft? Was it required?
No, sir. No, ma'am. No, ma'am. It was not required.
And your antibiotic prophylaxis, or rather, it won't be prophylaxis, therapeutic antibiotic regimen remain the same?
Yes, ma'am. Remain the same.
And you preserve it with an antibiotic solution and antifungal.
Yes.
What antibiotic and what antifungal you have used?
So ceftriaxone and metronidazole solution, sir.
So you directly instilled that into the container?
Yes, sir.
Do you have any evidence in favor of this? Because I've not read this, that when they preserve the placenta, preserving it in a container containing ceftriaxone, metronidazole, and fluconazole. So you must have looked up literature. Is there evidence in favor of that? Or is it just a local protocol?
Before I started this comparison studies, it was already being done. So I did not.
So, okay, I understand. Since it was already done, you didn't do any, but I would encourage you to, look up literature to see whether there is an evidence favoring, putting the graft in an antibiotic solution, right?
Okay, ma'am. Thank you. Thank you.
Our next speaker is Dr. Punardeep Singh. Ma'am? Ache ma'am, he's there. He's coming. After that, Dr. Amit Kumar Das, please be ready.
Good morning, everyone. Today, I, Punardeep Singh, PGT first year from General Surgery Department, is here to present an e-poster on management of post-burn contracture neck in a teaching hospital. We had an 8-year-old boy who had a post-burn contracture over the anterior aspect of the neck, causing difficulty in the neck movement, right shoulder movement, right arm movement, jaw movements, problem in speech, and problem in feeding. So a split skin grafting was decided for the patient. The post-burn contracture, as we know, is one of the most common sequelae of the burn. These contractures may cause problem in the movement. They can be present anywhere. They are mainly formed by due to the disorganized formation of the type 3 collagen, and so later on split skin grafting was decided for the patient. Thank you.
Dr. Punardeep, two observations before I ask you any question. Whenever you use a clinical picture of a patient,
Yes, sir.
it is ethically incorrect unless you hide the identity. So next time you make a poster, just put a black mark on the eyes.
Okay.
So the patient's identity should not be disclosed. That is one. Second is that you've put an abstract on top.
Yeah.
An abstract is done only if you have written an article. So you cannot have an abstract in a poster, right?
Okay.
So if it is a short case report or something, that is it.
Sure.
Because it is a case study.
Yes, ma'am.
It is a case study. So you could have just case report, right?
Report.
So case report, you could have just started with the history, a brief history of the clinical presentation, and then what you did.
Okay.
Your management discussion, everything is what is generally done. It should be, what have I done for this patient?
Okay.
Fourth, the release of a contracture and treatment with a skin graft is a standardized regimen. So if you talk about the uniqueness of your presentation, there is not much to say about.
Yeah.
Fifth, if you want to give pre and post-op pictures, a good idea will be, like if you see the child could not extend his neck, right, pre-operatively.
Yeah. Yes, ma'am.
So your post-operative picture should show the level of extension. Rather than a smiling face, which is really welcome, but I would appreciate to see what is the range of motion now. Now, if it was a video, it would have been very easy. But in a poster, next time you do it, just show with the image how much he can extend his neck back.
Sure.
Right? So these are some of my observations for your case.
Sure.
Yes, please.
Standard management. Okay. Okay, sure, sir.
Wrote that abstract, no? That should have been the background or introduction. And in that background introduction only, you should be able to put your novelty of this case. Why are you presenting this case?
Sure, sir.
So there only you should have mentioned that.
Sure.
The novelty of your case.
Sure. Thank you, sir. Thank you, sir.
Next, Dr. Amit Kumar Das. Absent. No. Amit Kumar Das.
लास्ट मंथ में से ये नहीं खुलेगा না এখানে আছে দাও দেখো তো অমিত কুমার দাস আমি সেভ করেছি
স্যার নিচের হানিয়া দিয়ে আছে কি স্যার নিচেরটা চলে স্যার তাহলে এইটা
এটা না হ্যাঁ
ওটা রিটার্ন ফাইল করুন
এটাও করবো না
ক্যান্সেল করে দিন এটা ক্যান্সেল করুন
হ্যাঁ ঠিক আছে
Good morning, everyone. Good morning, everyone. I, Dr. Amit Kumar, PhD is JR2. So I am here to present a e-poster in Amiens hernia. Topic is Amiens hernia. Introduction. Amiens hernia is defined as incarceration of appendix within the inguinal hernia, and Amiens hernia becomes inflamed, infected, or perforated, and the appendix may also be incarcerated and entirely healthy. Amiens hernia, named after Claudius Amiens, who on December 6, 1735 performed first successful appendicectomy during the treatment of 11-year-old boy who presented with right inguinal hernia. Case report: a 52-year-old male present to the surgical emergency with pain and swelling in right inguinal region for last 2 days. The pain initially started in the periumbilical region, then radiated to the right iliac fossa and had reducible swelling. Right inguinal region. He had the history of vomiting, fever for 2 days. The patient had reducible swelling in the right inguinal region since past 2 years, which had become irreducible in last 2 days. Patient vitals were stable, except for tachycardia, and patient was febrile. On local examination, a tender irreducible swelling was present in the right inguinal region. Cough impulse was not present, and scrotum examination was normal, and testis could be felt separately. Abdomen was mildly distended, and tenderness was noted over right iliac fossa. Okay, ma'am. Okay, ma'am. Amiens hernia is the rare presentation of inguinal hernia in which the appendix is incarcerated. Okay. Okay, sir. So in summary, inguinal hernia, sir, hernia is repaired by darning method, sir. That's it, sir. So appendix is inflamed, so we are appendicectomy. Obstructive, so yes, sir. In CT scan, it's Amiens hernia, appendix in the hernial sac.
Yeah, Dr. Amit. Again,
Yes, ma'am.
this is not how a poster is to be presented, so I'll summarize that for everybody later on. But there is a way, what Dr. Amit Roy just asked, that he asked you what did you do with the appendix? There is something called a Losanov classification of amide. Have you read about that? So when you present a poster, please read up the topic. It's not just presenting what you've done, because that is exactly what the Losanov classification says, that the hernia repair remains constant, but it is dictated by the state of the appendix. If it is a healthy appendix, you can do an appendectomy and put a mesh.
No.
If it is an inflamed appendix, then you will also, healthy appendix, you may not do an appendectomy and put a mesh. If it is an inflamed appendix, you have to do an appendectomy. And that is where but if you see it's just the tip inflamed, the rest is good, you can still put a mesh. If the whole appendix is inflamed, if there is surrounding cecal inflammation, you cannot put a mesh. So unless you can classify your amide hernia, you cannot plan, like, because sir just whispered to me that the appendix was healthy.
I think that is why you could get away with the mesh. Second is 52-year-old darning. Yeah, that's what I'm saying. 52-year-old darning. Yes, I wouldn't say it is wrong, but today's era it is difficult to say whether you will do a darning or not. And again, the image, I would have preferred it larger. And your hernia, I mean, what are you saying? It is a appendix within the hernial sac,
Yes,
right?
ma'am.
So did you have a pre-operative diagnosis of this patient since you do a CT?
CT scan.
So
in
did
CT
you have a
scan
pre-operative diagnosis?
diagnosis? Yes, ma'am.
I mean, why did you think that it is going to be an amiant?
Ma'am,
Clinically, there is nothing to suggest an amiant. And even in hernias, we don't do a CT normally, inguinal hernia.
Yes, ma'am.
So since you did the imaging, there must have been some doubt. So what was it that made you do a CT scan?
ma'am, here the patient has bowel sound absent and the feature of obstipation.
So those are all features of obstruction.
Obstruction.
I mean, CT scan and that too with contrast. So that was done with what in mind? You were not looking for an amiant. I think when you went in for the OT, you found an amiant.
Yes,
That is the classical way. But was the CT done with any specific intent? Also, could you pick up the amiant in the CT? The image is too small, I can't see it. Could you pick up the, if you've
Yes,
done
ma'am.
a CT, you should be able to see the appendix within the, could you see it?
Yes, ma'am. There's
You
appendix
can
in
you
the yellow arrow.
Yeah, can you blow up the image, please? Can you just enlarge the image? Yes, no, push it up. শরৎ একটু করে দে আচ্ছা ঠিক আছে না হলে ছেড়ে দেন Went in, you were already prepared with a roadmap, isn't it?
Yes.
Okay, now that you see it, what do you see in the appendix? Now tell me.
So ma'am, there is a hernial sac. Appendix is there, ma'am.
Right, but what is specific about the appendix? The yellow is the marker to the appendix.
appendix,
What do you see in the appendix? Something very obvious in this image. Can you appreciate the feculates there? There are those black dots inside
Yes,
the appendix,
ma'am.
right? So yes, so there were feculates. But the patient was in obstruction, you said. That obstruction was due to the hernia, but the appendix seemed to have been good. It's not an acutely inflamed. There's no edema in the appendiceal wall. Yeah, yeah. Obstructed, not strangulated.
Yes, ma'am. Yes, ma'am.
Sir, I think this is where the CT came in, that if it was strangulated, frank strangulation, they would have probably not gone for the CT. The patient probably had no features of peritonitis, just features of obstruction. Yes. Yeah. Mm-hmm. Then the CT is not done. Yeah, that is exactly what I wanted to know, that what was the reason behind doing a CT scan?
Every hernia gets ultrasound now here. So probably the sonologist told that there is a possibility of appendix, and that's why I think so. I think so.
That's okay. Academic interest, documentation, it is an accepted thing.
Yes.
See, there are two things. It's not obstructed. We do not have gut dilatation. There is contrast in the distal colon. So clinically, probably not. It was an irreducible hernia, probably. And that is why, yes, yes, sir.
Last actor.
Our last speaker is Dr. Shalini, and she'll be presenting a paper. No, ma'am, no. Different. No, nothing to be done. Just one paper presenter.
Good morning, professors. Myself, Dr. Shalini from Katihar Medical College, going to present my topic, study on transurethral resection of prostate for symptomatic BPH presenting in tertiary care hospital. Benign prostatic hyperplasia is a common chronic progressive disease resulting in the enlargement of the prostate gland and bladder outlet obstruction in the aging men. With the aging of society and extension of life expectancy, more and more patients are diagnosed with the massive BPH. TURP has been the gold standard in the treatment of prostatic hyperplasia, requiring surgery against all the newer modalities are compared as it provides durable treatment. Those having persistent symptoms or who have failed trial of catheter removal were taken up for the surgery. Increasingly, such treatment is being provided by the laser ablation of prostate using helium LEP, green light TUMT, transurethral resection of prostate remains an effective treatment for bladder outlet obstruction due to prostatic growth. TURP has a steep learning curve which is better supervised by a senior person, reducing the incidence of complications and need for re-intervention. In this study, we review our experience with TURP as an alternative to open prostatectomy in properly evaluated patients to determine its efficacy and implement in centers where vapor prostatectomy or helium LEP is not possible. Patients and methods. This is a retrospective study conducted in Katihar Medical College. The medical records of patients undergoing prostatic resection in the period of June 2024 to May 2025 were examined and taken up for the analysis. The parameters included where age, size, or volume of prostate as determined by transvesical ultrasonography, preoperative hemoglobin, serum PSA levels, postoperative blood transfusion requirement if needed, duration of surgery, length of stay, and immediate and late complications along with overall outcome. Informed consent was routinely obtained from all the patients for use of records for research purposes. Clearance from the ethical review board was taken for the study. Patients presenting in OPD or rural surgical clinics with lower urinary tract symptoms were evaluated for the cause, and patients diagnosed to have BPH were further evaluated for prostatic size, associated comorbidities, and fitness for anesthesia, and to undergo TURP in lithotomy position. Patients assessed to have prostatic size more than 100 grams, those who have been associated with vesical calculus or undergoing open prostatectomy were not included. This is the exclusion criteria. In total, 47 patients were included in the study. Patients were anesthetized using 3 ml bupivacaine heavy with clonidine as a subarachnoid block given under aseptic condition. Cystourethoscopy was done using 19 French sheath with 30-degree Karl Storz cystoscope to evaluate urethra, prostate, and bladder mucosa. TURP was done using 26 Karl Storz sheath and rectoscope with unipolar cautery, removing prostatic tissues from median and both lateral lobes till just proximal to verumentonum using the cutting current of 150 watt and coagulation of 100 watt till capsule was barely visible. 1.5% glycine was used as irrigation fluid at a height of about 1 meter from the patient. Glycine is readily available here, though some uses 5% dextrose or sterile water for the same. Observations and results. In total, 94 patients had undergone TURP for BPH. The age range varied from 56 to 84 years with an average of 67.94 years. The weight of prostate varied from 32 grams to 76 grams with an average of 44 grams. On cystoscopy examination or ultrasonography, commented 24 patients had prominent median lobe, while in the others there were enlargement of bilateral lobes only. At presentation, 14 patients had a hemoglobin level less than 12 gram and it varied from 9 to 16 gram. The average hemoglobin in the group was 13 gram. In the post-op period, 6 patients had to be transfused blood, of which 4 patients needed 2 units of packed RBC. Complications observed in the immediate post-operative period were prolonged or excessive bleeding from the prostatic bed was seen in 12 patients, necessitating longer irrigation and length of stay. Breach of prostatic capsule or tear was observed in 4 patients and in 2 cases associated with leak of irrigating fluid into the peritoneal cavity. This resolved on conservative measures only. 8 patients had clot retention or leakage along the side of the Foley's in the post-operative period, possibly due to dislodgement of the clot or pause in the irrigation. 8 patients had UTI or dysuria in the post-operative patient. 2 patients developed retention 10 days after removal of the catheter and was resolved on dilatation of urethral tract. 6 patients had persistent dribbling in the post-op period due to weakness of the sphincter. This improved over a month of 4 patients, while 2 patients had leakage till about 4 months before resolution. None of them had any persistent urinary incontinence in this series. All patients had symptomatic and subjective improvement in urination following TURP. None of the patients had TOR syndrome or erectile dysfunction. There was no mortality in this series. Among the 94 patients taken up for surgery, 24 were under treatment for hypertension and 8 more were found to have raised blood pressure during workup and were started on the medication. 8 patients in this series had diabetes. 12 patients had COPD or asthma, but no other complications attributed to it during the operation. 4 patients having some ECG changes had no difficulty in undergoing operation. Catheterization time varied from 18 hours to 7 days with an average of 2.8 days. Operating time for the series was 48 minutes, varying from 29 to 85 minutes. Mean duration of hospital stay was 3.02 days, varying from 48 to 7 days. Blood loss was estimated to vary from 0.8 units to 3 units with average of 1.6 units of patients, 6 patients requiring transfusion. Conclusion, this is the small observational study with 94 patients undergoing TURP with good outcomes. TURP is typically an elective procedure used to treat prostatic enlargement resulting in symptomatic bladder outlet obstruction. Because of this, appropriate indications and discussion of the complications associated with the procedure require an integrated interprofessional team to communicate effectively and initiate treatment plans so the patient and family have appropriate expectations. This approach will ensure that patients are adequately prepared for their procedure and what to expect. Patients who are better informed are more invested in their decision and are happier with their outcomes. The procedure is elective and irreversible. Thank you.
We'll be having a short tea break of 10 minutes, and after that, please join us for an exciting round of quiz by our ever enigmatic quiz master, Dr. Kaushik Bhattacharya, sir. Thank you.
Acharya sir with you. And not to forget the attractive prize money too. So, Kaushik sir, the stage, the hall, and the entire audience is yours now.
Just before Kaushik sir takes the center stage, I would like to make the PhD sit according to the team. Team A, on my left-hand side, Dr. Sushant, Dr. Gurbir, Dr. Navjot Sandhu, sorry. Ma'am, সামনে বসুন না, ma'am. Team A, Dr. Sushant, Dr. Gurbir, Dr. Navjot Sandhu. Team B, here down, Dr. Simran, Dr. Rakhi, and Dr. Aprajita. Team C. তাই চারজন আছে, এভাবে হবে না।
টিম সি এখানে করতে হবে।
টিম সি কে তিনটা করে দিচ্ছি। টিম সি, Dr. Ramendra, Dr. Hassan, and Dr. Shivang. Here. সি কে ডি করে দিলাম, বি কে সি করে। Dr. Ramendra, Dr. Hassan, Dr. Shivang. Team D, Dr. Wajida, Dr. Robin, Dr. Pranay, Dr. Abhishek. Team E, Dr. Jaspreet, Dr. Amrit, Dr. Vikas.
पेपर मिलेगा।
Team E. Team F, Dr. Ghayur, Dr. Akash, and Dr. Arzu. तुम लोग चार हैं ना? तुम लोग कितना है? अच्छा अच्छा ठीक है। सॉरी, टीम ई, डॉक्टर जसप्रीत, डॉक्टर अमृत, डॉक्टर विकास। टीम एफ, डॉक्टर विशाल, डॉक्टर अमित, डॉक्टर राज कंवर। टीम डी, सॉरी टीम जी, घयूर, डॉक्टर घयूर, डॉक्टर आकाश, डॉक्टर आरजू। एंड लास्टली टीम एच, डॉक्टर दिवाकर, डॉक्टर शहनवाज, डॉक्टर रौनक, डॉक्टर पुनर्दीप बीच में।
টিমগুলো লিখে না, ABCD করে লিখে। No, it is not part of the quiz. This is Shara's introductory slide. টিমগুলো লিখে দাও সামনে। I'll request everybody, the teams, to just put this sticker in front of them. দিয়ে দাও ABCD जो set. All set? Can we start? Okay. Respected Vice Principal, Vice Chancellor Sir, Professor Sudipta Bose, Vice Principal, Professor Aswadev Roy, on behalf of Professor Hiranmay Bhattacharya, Organizing Chairman, Dr. Sharad Shangdan, Organizing Secretary, Dr. Mala, Joint Organizing Secretary, and Professor Saibal Kumar Mukherjee, Program Coordinator, I welcome you for this quiz program. I also welcome the four distinguished dignitaries who has come all the way from Kolkata for this, and it is my honor to have you all, madam, sir, in front of me for this quiz. Now, this quiz program, let me tell you, madam, and Sudhir sir, where is the other two left? Acha, okay. Sudhir sir, we started about this program 15 days back, and we used to have 9 o'clock, 9 p.m. every day, one online quiz in our PG group WhatsApp group. PG group, hey, Suman, PG group WhatsApp group at 9 p.m. every night. I used to put one question, and I used to see all the PGs used to be so excited, and we used to have fastest finger first thing. So in that one, we had about one round also for faculty. One was a mixed bag, and all it used to be full questions. The questions extended from, we had questions from Shahid Kapoor to Klatskin tumor. So you can understand we had the length and breadth of questions, and everybody participated in that. So now we have come to the final quiz where we are going to have 6 rounds. I welcome you all for this, and it is my honor to have this quiz questions. The rules regulations are very clear. For the right answer, you get 10 marks. Am I audible? For the wrong answers, you get minus 5 marks. And I am assisted by Dr. Sharad, who will be taking care of the time limit and also the score. So we have 15 seconds for the direct questions, and we will give only 5 seconds or maybe less than 5 seconds for the bypass questions. We will also have in between, I was expecting 9 teams, but then I am finding there's only 8 teams. So the 9th question will be always an audience quiz. So I'll be asking the audience to also interact and get the thing. Now about the rounds, we have 6 rounds. The first will be basically an operative surgery and surgical pathology. The second round will be a historical milestones in surgery. The third round will be Indian surgical achievements. The fourth round will be surgical inventions. Then we have the last round, penultimate round will be surgical quotations and nickname. And the last will be a mixed bag. Now, there will be a quiz which may be a little bit difficult. I don't want to be a high scoring match. But then believe me, it will be also questions where I want all of you to attempt. And no whispering. See that the answer does not get leaked out. And I'll request everybody to take out their mobile phones and smartphones, smart watches, if anybody, any of the teams have, to keep it away. I don't want any mobile phones, smart watches, any type of things in, otherwise we will disqualify you from this contest. Now this quiz has got a very high prize money. The first prize is about 10,000 rupees. The second prize goes about 5,000 rupees, and the third is 3,000 rupees. Am I right, Sharad? That's what. So I think the first time in MGM we are having such a huge prize money, and when we went to our registrar for this, he was immediately magnanimous enough to sign this 3 cash awards for this. So it is going to be a high thing for the quiz. So we start with the light went off. We start with the surgery quiz 1, and the question goes to team A. Is the team A ready? Yeah. So we have now bringing the, we'll wait for the light, or we don't want the light? Wait for the light, okay. No, I can't go what my Sharad does not, allow me to do. So Sharad says we'll wait, so we have to wait. So, yeah. How long the light is going to come? Okay, team A, no whispering. See to that your back people don't listen to your answers, and try to give in 15 seconds. Don't be in a hurry to give the answers. 15 seconds is a decent time, and I'm sure you should be in a position to get this answer. All smartphones, smart watches, please away. I don't want anybody to immediately. Yeah, smart people. কি কতক্ষণ লাগবে ভাই? হ্যাঁ স্যার Okay. So team A, the first question going to come in the board. Look at the board. Where is a Fowler ware incision given? Your time starts now. You know it. Try. I think that should not be a problem. Where is the Fowler? Okay, time up. Team B. Team C. Team D. Team D. One. Don't shoot. You are Team D. Yeah. What's the answer? Yes. Team E. F. Pardon? Okay. G is there? G? Pass. Okay. H is there? All right. That's all, no? No other questions. The first question goes off. I think that's a very sad thing. Fowler ware incision is given for appendicectomy. I didn't expect you not saying appendix. If you have a Rutherford Morris incision, if you extend it medially, it is known as Fowler ware. If you extend it laterally, it is known as Rocky Davis incision. So Fowler ware incision is given for an appendicectomy. Okay, now the question goes to team B. Are you ready? All right. All ready? Answer? Yeah. पास में नहीं होता right? B, now team B. Yeah. I'll put one organism. Name the organism. The moment the thing comes, your time will start, okay? Your time starts now. Pardon? Team C? Yes. They get the bonus point. So team C gets the bonus point, Sharad. That's the answer is Helicobacter pylori. It was discovered in 2005 by Barry Marshall and Robert Warren, and they got the Nobel Prize for that. Yeah, they will get the -5. They will get the +5. They got wrong answer. All right, Team C, are you set? So first scores by Team C. You're opening the amount. Dikhara? Yeah. So Team C starts the ball rolling. So we get the third question. All you have to do is name the hernia. I'm going to show a picture. 15 seconds will start. Don't be in a hurry. Name the hernia. Name the hernia. Time up. So next team is Team D. Can you repeat what it says? Springial. I will not give that. But you said something before that. What did you say? Yeah, but why you gave two answers? You give me one answer. I don't want you to give two answers. No, I don't want this. 4 people, 2 answers. I will not accept that. So -5. Next team, Team E. All right. So are you going to do a little bit more extension or anything like that? Spigillin, he's always said, I will not accept that. Lumbar hernia, I could have, if you have given me the full answer, I would have accepted, but you're not giving me the full answer. That's the only problem. Okay, next team. Name of the hernia. Anybody else? Team. Wrong. Next. You. -5 to that team. Sharad. minus 95. He said petit hernia. Yeah, past question. Yeah. Anybody else? All teams done? All teams done? क्या हो गया? All teams done. Shall I throw it to the audience? Anybody from the audience? This is known as Glenfield hernia. I would have accepted an answer if you had said superior lumbar triangle hernia, because lumbar hernia I will not accept this because there is something called a inferior lumbar also. So I am not accept an answer like lumbar hernia. That is a minus 5. So the hernia will have a Glenfield hernia will have a 12th rib as a lower border. There will be internal oblique muscles, and then there will be erectospinal muscles. That hernia is known as superior lumbar triangle hernia. So next question should be given to, next question is yours, team D. Are you all set? Please give one answer. I don't want 4 people giving 4 answers. What is this classification known as? I'm going to show a picture. Take your time, 15 seconds, tell me the classification. I think you know that you have seen this hemorrhoids. What is this classification known as? Whose name this classification goes? Time up. Next. Pass. Okay, next. What classification? No, it's not Parkland's classification. Okay, now we go to the, after them, Sharad, who's next after that? That side. G. Pass. H. Anybody wants to try? A. B. C. What? Goodsell's classification says wrong. I think he is wrong. Shall I give the answer? All right. Anybody in the audience? This is known as Golligler's classification. This goes by the name of John Cedric Golliger. So it's a very, you all read it. You know it's grade 1, grade 2, grade, every day you are telling me, but the name is, it goes by the Golliger's name. So the next question should go to team E. D, E, O. Only 2 members, huh? All right, I'm going to show you, again I have to wait, huh? Can't they keep the generator on for some time? जेट चला के रखने बोलो, इसको बोलो. All right, so now the next team, whom I'm going to say, who's you are, okay. I'm going to show you something. What is this liver resection known as? Okay, what is this liver resection? I'm going to show a thing and just you tell me what is this liver resection known as. This is a resection, S5, S4 and this thing, and you take it out. What is this resection known as, liver resection known as? All right, what about the next team? You are team F. No. Okay, next, after F, we are having D. We are going to D, yeah, Sharad? G. G. Yes, I think I'll give the answer to them. They mentioned the word Taj Mahal. This is known as Taj Mahal hepatectomy. All right, because the dome shape, the thing is known as Taj Mahal hepatectomy, and it has been recognized by all the journals. It has been recognized everywhere. It is now known as, it has also been done by robots. So it is known as Taj Mahal hepatectomy. Okay, the next team, 2 is to be E. Tumhara. F. All right. I'm going to show a picture F. All right. Please look at the picture. Please be active. This is a picture. All right. And the questions will be, look at the picture. All right. Hey, no whispering and all. What are the ducts of the sublingual gland known as? What are the ducts of the sublingual gland known as? You can look at the picture again. What is the ducts of the sublingual glands known as? Yeah. Your turn now. Huh? Wharton's duct. No. All right, next. Next team after you. G. Yours. Yeah. What are the sublingual glands ducts known as?
There is no negative marking of passing question.
You can try, yeah. Something you can try. Okay, next team. Yeah. Pardon? Can you spell it? Can you spell it? Come on, you know it. V. V. V for victory. No, I will not give the answer to you. Any other team after this? A. B. C. All right. Spell it. Yeah, that's the thing I was looking for. You have a small duct which is known as duct of Rivinus, and the larger one is known as Bartholin's duct. Okay? Yeah, +5. To team C. Are they showing it here? Okay. Team C is leading, huh? And this is the two people whose name it is, basically, Augustus Rivinus and Caspar Bartholin the Younger. Based on them, the ducts have been named. So next question should go to team G. Okay. Identify the structure. One structure will be coming, and there will be one black. I've labeled it as a black, and there's a question mark there. So you have to identify the structure, just that structure. What is this? You have 15 seconds. Identify the structure. Time up. So that next team. H. Come on, H. उसके बाद next. A. B. C. Pardon? Posterior tubercle of thyroid? No. Name of the structure. D. Yes. So D gets the point. This is known as tubercle of Zuckerkandl. You can see this. And why it is important? I'm not going to give marks for that or cut marks. Yes, that's a place. On table, on operating table, you see this. It is also known as posterior horn of the thyroid. Basically, it is an important landmark for the recurrent laryngeal nerve. All right. So next question should go to H. Where is H? Okay. H, please look at the slide. It is a little bit of pathological slide. It's not pathological. It's a search from pathology. In a case of post-splenectomy, what is this in a peripheral smear? Okay. I'm going to show the picture and you tell me what is this. What is this in the peripheral smear in a case of splenectomy you get? No. Next team is A, B, C, D, E, F. Anybody else? G? G is there? G? Arre, try so karo. There is no negative marking. No, now your time is up. You can't try again. All right. Any other team left? All right. H? What the bola? No, they're bypassing. All right. The answer has to be. I don't know why it was not answered. And this is basically the answer is Howell jelly body, which is named after William Henry Howell and Justin Mary Jolly. We have a vice principal here who happens to be also the HOD of pathology. I'll ask him, can they give somebody the mic there? If he wants to add one question on that, sir, you would like to add something on this Howell Jolly bodies?
No, sir. Now, since the question was on Howell Jolly body, can anybody, sir? I think if they can answer this question, you can add 5 marks more to any of the teams. What can be the differential diagnosis? If you see, if you look at a Howell Jolly body, what else can you think of? This differential diagnosis of that Howell Jolly body. You can raise your hands and answer. Yes? No, I'm not asking you to diagnose the disease. I'm asking you to differential diagnosis of that body. Yes, here.
You give the answer. We'll.
I'm not asking the condition.
No, I think you give the answer, sir.
Yes. So there are other bodies like Heinz bodies. You have Pappenheimer bodies. So you have to differentiate these things from Howell Jolly bodies. And this Howell Jolly body, apart from post-plenectomy patient, one more important condition, commonly encountered condition where you get it is megaloblastic anemia.
All right, we have come to the end of this round. I'm just throwing this question. This is only for the audience. I don't want anybody else to answer. No contestant. Just because the 9th question, I thought there will be a 9 team sometime. The Katiyar was supposed to take part in this, but I don't think Katiyar is there. So we have only 8 teams from our college. This question I'll throw open to the audience. What is this abnormality in liver? When you see the liver, you find there's abnormality in laparoscopy. You put your foot at the gallbladder there, but there's something there in the liver. What is this abnormality of liver known as? Okay. Anybody from the audience? Okay, I'll give the answer. The answer is it's known as Riedel's lobe, which is a tongue-like inferior projection of the right lobe of liver beyond the liver of most inferior costal liver, and it's an anatomical variant. Sometimes you get to see in this. Now I'll ask one more question for the audience again. For the audience only. See this picture. What is this? What artery is this? Pardon? Audience? अरे वो ना आर्टरी का नाम बोलो, वो तो मैं समझ गया सर के. This is known as corona mortis. Yeah. Which is known as crown of death. Is a vascular connection between the obtruder artery and external iliac or inferior epigastric artery. All right. At the end of round 1, I'll ask Dr. Sharat to tell the scores.
So Team A has 0, Team B -5, Team C 10, Team D 5, Team E 0, F -5, G 5, and H -5. So Team C is leading right now with 10 points in total.
All right, now we have exciting more questions. So I want all the teams to now shoot. This was a surgical thing. Now we are going beyond surgery. So the second round will be on history. So question 2, which team will get the question? A. All right, A, you're set. See this picture. This was a picture which was drawn on a copper plate by the person who wanted to have the thing, and he did not know what he has discovered. And he made 8 copies of this, and he has sent to different places in the world to find out, because he didn't know what he has drawn. And he said, should I call it an artery or a vein? I never found blood in it. So he was totally confused, and that those days you didn't have internet. So he has posted those things, and he has sent people to that to save 8 people, the topmost surgeons in the world, to get an opinion. He has discovered, but he didn't know what he has discovered. He has made this copper plate and sent to 8 people. 7 disappeared, only 1 remained. Okay, this is our thing. Now, the question is, what was the discovery and who was the inventor? Team A. Team A. What was the discovery? Team B. Team C. D. Team C, yeah. Team D. E. F. No. Can you be a little bit more elaborate? And who was the inventor? Pancreas to दिख रहा था उसी में, but who was the inventor? G, H, and who was the inventor? I think pancreatic duct, Sharad, I can give him half the marks. So, I think he has made that effort well. So give them hard, but he could not name the person who did that. The answer is it was none other than Johann Georg Wirsung, on whose name it is the duct of Wirsung is. And unfortunately, because he did not know, and he did this discovery on a cadaver of a criminal. Those days you don't get criminal cadavers. So one criminal was given to him. He sat through the whole night, and he was assisted by 2 people and 2 of his students, and they did the discovery of the pancreatic duct. He didn't know what is it, so he sent to 8 people for a peer review, like we do in a journal nowadays. So we want to know what is it. Unfortunately, because he discovered that, Wirsung was assassinated in front of his house. Okay, and the reason when they did the thing, why he was assassinated, why he was killed, it was said that there were many reasons. One reason was one of the students who assisted them. Then that he claimed, I have done this. Wirsung has taken the credit. So it was a thing where this man lost his life for this pancreatic duct. Okay, now next team is, who's going to get? You are going to get. Team B. Get set, see the questions, and after I ask the question, you answer that, okay? 18th June 1815, Battle of Waterloo and the defeat of Napoleon. Okay? The question is, what was the cause of Napoleon's defeat? Your time starts now. What was the time, what was the reason for Napoleon's defeat? Team C. Team D. Yeah, Team D. Team E. F. G. H. No. Stomach cancer he had, but he didn't die because he didn't lose the battle because of that. And this is the reason why he lost the battle. He lost because of hemorrhoids, and that's why the hemorrhoid is now known as pile of defeat. Okay? He lost it. It was so heavily bleeding, he was not able to go to the battlefield. And the treatment they did for Napoleon was, those days, they put leeches, okay, just before, so that they suck the blood and the blood becomes, the bleeding becomes less. And in that way, they put leeches on his rectum so that the leeches take the blood away. And then he was told to go and fight the Battle of Waterloo in a completely emaciated and lost the battle. So that's why hemorrhoids is known as nowadays pile of defeat. All right, now next team is C. C, look at the picture and tell me who is he and why is he famous. There's a picture of who is he, and this man was told once only a person with brain damage will do a laparoscopic surgery. Who is he? Yeah, try. Team up. Team D. Team D. Team E. F. G. Yeah, but what's the name? Gynecologist to main samajh gaya. What's his name? G. Yeah, okay, I accept that, but I want the name. Because I'm not asking his why he is famous, who is he? G, H, I, H, yeah. G, H, A, B, C, C ho gaya na? Okay, now we are done. This I expected you to tell. This is a gynecologist. Pardon? There was only two gynecologists who has contributed significantly in surgery. One was this man called Kurt Sem, okay, and you won't believe he did the first laparoscopic appendectomy, and then it was not accepted by the entire world those days. He was told when he was presenting the case in the podium, he was told only a person of brain dead will do such surgeries. Somebody in the back of, when he was presenting the case, the first time laparoscopic appendectomy, somebody in the podium switched off the light. Okay, they said, you can't present this is a useless surgery. So they switched off the light so that he cannot present. He pushed this paper for the first time in American College of Surgery, American Journal of Surgery. It was rejected. So he has really struggled to establish his thing, and now what you are doing is because of him. And if you see him, those days there was no assistant. So he was the first person to put the camera fixed on his head, and he used to do laparoscopy. So with the head like that, single man, there was no assistant. With the head, he used to do the camera, he used to move the head, and he used to do the laparoscopy. So that's the man who is Kurt Sem, who did the first laparoscopic appendectomy. So the next question goes to Team D. All right, Team D, you should get this. A scrub nurse, what is her contribution to surgery? She was not a surgeon. She was only a nurse. What was her contribution to surgery? A scrub nurse. No, time up. Team E. Yeah, but all right, I'll give the answer to them. Yeah, you get. Yeah, it's okay. You get the point. I'm not going to cut your points. Her name is Caroline Hampton Halstead. Just now you heard all about Halstead's contribution. Sir was telling about Halstead. It's his wife who was to assist him in all the surgeries. And one day Halstead saw that her hand is having lashes, and Halstead was in love with that scrub nurse, and ultimately they got married. And then, he asked the Goodwear company, the one which you see in making pads, he asked them to make a gloves for her. And that's the first time gloves were used by the surgeons. So what gloves which you are using every day, do thank her for making your hands safe. Okay, the next question goes to E. All right. Again, I'm going to show you a picture. Look at the, don't be in a hurry. There's a picture which you are showing that there's a number of percentage of thing in 1841, and then suddenly in 1847, somebody introduced chlorine hand wash, and the mortality in maternal mortality decreased, or puerperal fever cases decreased, the death decreased. Till before that it was very high rate, and suddenly somebody introduced this chlorine hand wash, and suddenly there was a decrease in the death rate. And the question is, all set, who is known as a father of hand washing or hand hygiene? Yeah. Don't discuss and don't whisper. Time up. The next team. Yeah, loss is there, sir is telling. So you don't discuss. Next team is? Okay. I think the teacher should not discuss. That's what. Okay. The next. F. No. E, F, G, H. Yes. Give the points, bonus points to them. So that's answer. The answer is Ignaz Semmelweis, who is known as a savior of mothers and who had decreased the maternal mortality rate significantly. And you know what was the result of this? During the COVID-19, we remember him really, because that is the time he used only 3 words: wash your hands. But there was such a big repercussion, such a big, nobody wanted to accept that, and the names which you hear nowadays, nobody wanted to accept them. And he was put in he went in depression, he was put in a mental asylum, he was hit, his leg becomes gangrenous, and he had his death. That is the ultimate fate of a man who said just 3 words: wash your hands. Okay, so that's the way he died, even though he made a significant contribution. And in COVID-19, we could understand the huge difference he made to us. Okay, the next team is F. All right, team F, get set. See the pictures again. See the picture. All right, don't answer. Your time will not start now. Next, your time will start. Okay, now you just see the pictures. How are they related? Team F, how are they related? G. G. No. How are they related? Listen. G, H. H. I. A. B. B. C. D. No. E. F. Okay. Okay. All right. I don't know. You see the arrow here? Why don't you see this arrow here? What is that arrow showing? He is the man who discovered parathyroids. He is Richard Owen, who discovered parathyroids in in Indian rhinoceros. Okay, and he said a small, compact, yellow glandular body attached to the thyroid at the point where the veins emerge. So that's what he wrote. And one of his other contribution apart from parathyroid was this. He was the man who was fanatic of dinosaurs. So he was the man who coined the term dinosaurs. Okay. Okay, next team. G. G, one instrument will come, and then you don't answer. I'll tell you when your time will start. Look at this picture. Look at this picture. All right. What is this instrument and who discovered it? I'll give you a hint. He was a world champion cyclist for physicians and pharmacists in 1987. Don't go by the hint. The hint may mislead you, but what was this instrument and who discovered it? Even if you give me a part of it, time up. Next. G tha na, Sharad? H. I. All right. Laparoscopic, all right. And any other thing you want to give the name of that person? Okay, I can give you half the score to him because he at least made the laparoscope thing. So the answer is, that's the answer. It's known as galloscope laparoscope, invented by Eric Muhe, and it was used for the first laparoscopic cholecystectomy in 1985. So what we are doing in the OT every day, sir, laparoscopy karna hai. That was the instrument which was used by this gentleman, Eric Muhe. But the problem is, yes, I was about to tell that. And that's the next thing, what sir has told you. If you read this quote, this was told by Lee Swanstone, professor of surgery. He said, the laparoscopic revolution began in the 1980s when Eric Muhe in Germany did the first laparoscopic cholecystectomy. He was reviled by his colleagues, lost his privileges, was jailed, and his wife left him, illustrating the dangers of being the first. All right, so many things happened. He was put behind the bars, as Professor Sehwal sir was telling. The reason, you know, because he did a CVD injury. And the nursing home where we did, the nursing home owner put the charges on him, and he was doing for the first time. It's not that that was the first time. The nursing home owner put the charges on him, though he only called him to do the surgery. And he only went and said, no, and they had a huge, those days it was not like that. You know, they said this person killed the patient, and he was put in behind the bars. The first person who did laparoscopic cholecystectomy. Okay, the next question goes to H. All right. H, please look at this pictures. I think all of you know this. There are a lot of things which is, there's a bovie and all those things. All right, so look at this picture. Sir wants to go. Sir, ki deri আছে না? কটার সময় যাবেন স্যার? So this is you understand what is it, no? Bovie. Who, what is bovie? Who or what is bovie? H. Sharad, H, na? H. Time up. I, naki. A. B. Inventor of. All right, I'll give to B. The all ladies team gets a point. Yeah, ye bol diya. She has told already. So B, I'll give the point to B because she has told that. I think I'll get that thing to there. The answer will be a person called Bovie, who is the first person, William Bovie, who was the first person to discover the diathermy. This was the first diathermy ever discovered in the world. Okay, that was done by him. And then, because he discovered the diathermy, this gentleman, Cushing, Harvey Cushing, could bring down the mortality rate from almost 80 to 90% to 10%. Because Harvey Cushing was the person who used this diathermy, and now he is known as father of neurosurgery. All this credit should go to Bovie, because Bovie only gave him that diathermy by which the blood used to stop, and then they could bring this the cost the mortality rate significantly down in a case of neurosurgery and other surgeries. She said that, electrocautery. Who was it then? No, I will give it to them, no problem. So that's a Bovie, who was a father of electrosurgical devices known as. And you know what happened to him? Any idea what happened to Bovie, the man who is, you are using the diathermy every day in your OT, and you know what happened to him ultimately? Pardon? No, he didn't burn his wife. No wife things. Anything happened? You know, this is what I published. This is the man who sold this thing for $1. He went in deep poverty, and he has to, the patent which he did for this thing, he sold it for $1. So ladies and gentlemen, all of you are using his thing in the OT. Please see what was his fate. He lost the entire thing and he gave it for $1. He sold the patent itself. So that's the Bowie. So next question goes to H.
Round finish.
Oh, round finish. All right. So round finish, we'll go rotate the audience. So no participant, just the audience, this thing. I'll give it to the audience. A surgeon remarked, patient sits up and walks out the operation room after putting in slippers and robe. Ordinary, he drives home. Nobody send them get well cards soon because he was having so fast recovery. And his daughter, the surgeon's daughter, remarked, after seeing the fast recovery procedure of his daddy, he said, "My dad loved drama. This was dramatic." Okay, so after doing the surgery, the surgeon remarking, the patient is sits up, walks out OT, puts in slippers, and he drives home. And the recovery, the surgery which he does is so good that the patient does not even get well card soon. No, it was true like that. The question to the audience is, what was the surgery or who was the surgeon? Laparoscopy. That's a problem. Anybody else? All right, I don't have much time, so I'll go to the answer. The answer is, it is Lichtenstein, which hernia we are doing every day in the OT. This is a man who did this, and he was credited for giving this such a good surgery. So I will Lester Lichtenstein. So at the end of round 2, Sharath, please tell us the score.
Team C still leads with 10 points, and Team A and B are yet to score, and Team F has -5.
So I want Team A, B, and F to now score. Okay, the third round is basically on Indian history. क्या चीज? Yeah, don't argue over the scores. That Dr. Sharad is taking care, so don't bother with the scores. Everything, that's why I put in black and white on the board so that everybody can see. So now we start on Indian history, Indian surgery. So all the questions, please don't say any foreign names. All will be Indian related. All right? Sakudayachin. All right. So we start the team. Question goes to Sharad. A set. If you happen to go to St. John's Church, Calcutta, you get to see this inscription stone. Okay? What is the significance of this inscription stone? You can read if you want. This is in St. John's, Calcutta. If you go there, you find there is a inscription stone in there, still there. And I have seen this. Okay, B, C, D, E, F, और कोई है? G, H, nobody? Okay. All right. I think all of you should go to Calcutta. All of you should go to this St. John's Church because it's one of the important landmark in India, and all of you should know. This is the highest amount of professional charges given to a surgeon. William Hamilton was a Scottish surgeon. He did surgery for the 10th Mughal Emperor Farooq Shah, probably with malignant distemper, which maybe is something like a carbuncle. That's what we think in 1717. And as a result of that surgery done by this Scottish surgeon, Emperor Farooq Shah gave him an elephant, a horse, all written there. 5,000 rupees of those days. 2 diamond rings. Hey, what happened? Sorry. 2 diamond rings, a jeweled alginet, that, you know, alginet, that head of gear, and set of gold buttons and models of all his surgical instruments in gold. So that is written in that inscription to stone. So that is the highest amount of professional charges a surgeon has got ever in his life. And that's written in St. John's, Calcutta. Okay, the next team is B. B? B, you should get this. All right. Who is he and what is contribution to surgery? Who is he and what is his contribution to surgery? Don't say any foreign names. All right, team C. Team D, E, F, G, H. Nobody. Oh my God. He was the person who did the first human dissection in Asia. All right, and if you happen to go to Calcutta Medical College or Medical College Calcutta, it was the first time done in 1836, and the picture is of Pandit Madhusudan Gupta, and this inscription is still there. He was the first anatomist, and if you go to the medical college, at least he would have said human dissection, I would have given the marks. He was the first person to do this in Medical College Calcutta. So that's the importance, and all of us learned this anatomy and surgical anatomy only because of him. Okay. And you know what has happened during the time when he went for dissection? He was Pandit Madhusudan Gupta, not an MBBS person, but he was called to do that. But those days in India, in Calcutta, there was a huge thing. You can't dissect a body like that because of a lot of religious things. So when he was doing this dissection in front of Medical College Calcutta, there used to be a separate, the Britishers put a full curfew-like situation because there was a huge crowd protesting that. But he did that. So that's the importance of this. No, they'll get, sir. No, sir. And that was the first decision in the world. Okay, next question goes to C. Why was Rupa Bai Fardunzi famous? Why was Rupa Bai Fardunzi famous? C. D. Female doctor, not first. Female doctor, second. D. E. F. G. H. Yes, they get the bonus point. So they get the bonus point because she was the first woman anesthesiologist in India and world. Okay, Rupa Bai Fardunzi was the first female anesthetist in the India and world, and she was recommended to go for, she was from Hyderabad, she was recommended to go to UK for training by Annie Besant. Okay, so that's the recommendation letter of Annie Besant. Okay, the next team is D. Okay, D, get ready. I'm showing who was the first professor of surgery in India. Who was the first professor of surgery in India? E, F, G, H, A, B, C, all up? How can you not know him? He is Lalit Mohan Banerjee, the first professor of surgery in India. He was the person who made ASI, one the founder member of ASI. He got his first MS degree from University of Calcutta. He was first surgeon to receive the Padma Bhushan. He was the first personal surgeon of the President of India. And last but not the least, he was the first surgeon to do surgery on a Nobel laureate, and the Nobel laureate was Rabindranath Tagore. Sir.
In his lifetime, he never used to write doctor, he used to write Mr.
Okay, so that's what he.
In that period, FRCs were not considered as doctors.
Doctors. Mr. And that's his tombstone in Calcutta still. So he did surgery for Rabindranath Tagore, who was having prostate problems and sepsis. So he did the suprapubic cystostomy on Rabindranath Tagore, and also, sir will know, Sharat Chandra Chatterjee. Okay, the next team goes to, yeah, E. Look at this picture. Okay, time starts now. What is the importance of this picture? Yeah, what is the importance? वो तो दिख रहा है, वो तो कोई बोल देगा. Next team. E. No. Next. You C. No. F. G. H. Okay, I think I can give to them. हाँ? ठीक है, इसको दे दो. No, but it's okay. We know the better. He has told the answer. So that's the first laparoscopic cholecystectomy, and the person who has done it is Udwadia. Dr. Udwadia here, and this is Dr. Deepraj Bhandarkar. So he got Padma Bhushan, everything because of this. The first laparoscopic cholecystectomy was done in India. Other one I already told. No, he said that India. India likha. Yeah, but this is the Indian round, so this is Indian round. Okay. No, it's okay, no problem. No, I think we can take Professor Sehwal sir as the ombudsman. Let him say. So this is the Indian history, sir. So I mean, the round itself is the Indian history. So Indian surgical thing. So we give it to them. Go to the next point. The next thing goes to F. Whose question? Yours. Okay, don't answer first. First I'll show you the picture. Who discovered the accessory artery of appendix? Again, don't say foreign names. Who discovered the accessory artery of appendix? Accessory artery is a branch from the posterior cecal artery. Who discovered it? Yes. It was a direct question for you. So they get the direct question. They have given the direct answer. So we give it to them. The answer is Sesachalam accessory artery of appendix was discovered in 1930. He was a professor of surgery in Bangalore Medical College, and this is his paper, in which it was brought out that there is an accessory artery of appendix also. The artery is nowadays named after him. So the next question is G. Where is G? Yeah, G. Who is he, or why he is famous? Who is he and why is he famous? Indian history, don't say foreign names. No try? Nobody wants to try also? G after that, H, no? H. No. Who is he? He did what? Next. Wrong. Next. A. B. C. D. E. F. All over? Any other team left? All over? How can you not know him? He is Mohan Desarda, on whose technique you have a hernia. Desarda's technique, have you heard this? So he is a man who discovered the Desarda's technique. Okay, now next question. H, yeah. If you can even identify the person, I'll give it the marks. Okay? Put this picture. The question is, what is the importance of this painting? But even if you can identify the person or what is happening, something like that, you can give it the. This is a painting which is there in now. Okay. A, B, C. All right. Mahatma Gandhi to theek hai. Kya ho raha tha? Okay, I'll give the answer to them. I mean, let them get the bonus point. The answer is Mahatma Gandhi in 1924 underwent emergent appendectomy, and that's the appendix being removed him. There's a OT list in his name was there, and this painting is there in Pune Hospital. And you know the importance of the painting? This was a surgeon who did it, Surgeon Maddox, who did the surgery on him. The importance of this painting is when Mahatma Gandhi was undergoing surgery in the Pune Sassoon Hospital, the light went off. And then somebody has to bring a लालटेन, उसको लेके देव पकड़ा, ठीक है, उसको पकड़ के महात्मा गांधी का ऑपरेशन हो रहा है. Can you believe this? Now somebody drew this picture and they put it in Sassoon Hospital. That room nowadays is still there. If you happen to go there, you can see this Mahatma Gandhi's picture. Now, as a result of this is not a quiz, but I'll tell you the GK's thing. As a result of this, Mahatma Gandhi was so upset, and I mean, he got so he got so afraid, and you know, the surgery was a nightmare for him. So, as a result of it, that Mahatma Gandhi, when he was doing the surgery of his knees, he requested the surgeon, I want to stay inside the OT. So that's Mahatma Gandhi sitting. His niece is getting surgery in PMCH Patna in the year 1947. Okay, so Mahatma Gandhi is sitting here and watching. Can you believe this? In this dress. And in the OT, the surgeon allowed him to make him sit because he said, I don't want to leave my knees and all. I want to sit and see. So PMCH allowed him. He was sitting there. And this is the first time an OT picture is coming with the outside people sitting in the world. Because they don't allow like this pictures to come out. The first time, because it is Mahatma Gandhi, he's sitting here. You can see in all the pictures sitting here. First time the pictures are coming out from inside the OT of an outside people sitting. Okay, now that's audience round because 9 questions are out there. Please see this picture. This picture happened to be the president of ASI in 1949, Panchanan Chatterjee. He was a founder member also of ASI. He was a professor of surgery in Calcutta Medical College. All right. And what was his contribution in the freedom struggle of India? I've given the rest. No harm, it's an audience one. So can you just tell me what was his contribution to the freedom struggle of India? A surgeon of repute, ASI president passed, but how did he contribute in the ASI, in the freedom struggle? All right, what he did was he gave a false certificate to Subhash Chandra Bose because Subhash Chandra Bose wanted to leave the country and he had a court hearing next day. So the court hearing, Panchanan Chatterjee gave a certificate that he is having sciatica. So he need not go. In that one day absence, he took his car and went out of the India. So that was a certificate given by Dr. Panchanan Chatterjee and helped the Subhash Chandra Bose. All right, so now again an audience question quickly. Anybody from the audience, can you tell them what is common to all of them? I'm showing you 8, 9 pictures. What is the common to all of them? Only audience, no participants. What is common to all? Again the pictures. Arthur Conan Doyle, Anton Chekhov, Michael Crichton, Somerset Maugham, William Carlos Williams. Pardon? They were all authors. All right, fine. You are a participant, so you will not get any prize. So now we will go for the round 4 and I will request Sharath to give the scores.
So team C and team H are in a tie position for first. Both have scored 15 marks and the rest have 5 and 0 of team A and B.
All right, team A and B, I want you to now score now. Now it will be a surgical inventions, okay? Little bit tricky, take your time. I'll give you 15 seconds, good enough time I'm giving. So the question goes to, who will get the question? A. A set. What is this? Or who discovered it? Anything you say, I'll give you the answer. I'll give you the score. What is this and who discovered it? B, C, D, E, F, G, H, All right. So I think we can give it to them. Any idea whose name it goes? Any idea? You said anastomosis, so I'll give it to them because a low scoring thing. Any idea whose name it goes? This goes by the name of Murphy's. You say Murphy's sign all those times. This is a man who discovered that, and this is known as Murphy's button. And he was the person who used this button to do anastomosis. The first time anastomosis was done by button. And see here, he's putting a gallbladder and a duodenum. So cholecystomy, everything, he used to use that button. So that Murphy's button was discovered by him, and that's how we came to know of the anastomosis. So now that's the thing. The next question goes to B. Thoda soch ke bolna. You should get that. All right. Take your time. After I finish, start this time. Okay, don't before that. Look at this picture. This is a picture drawn by somebody, and then he said, these glands are made to, in 1510, these glands are made to fill the interval where the muscles are lacking and hold the trachea away from the neck and bones as though they were a cushion. So this is what he has drawn. Okay, but he gave a statement. The question is, who was the artist bar personality? Time starts now. All right, we give the score to them, Sharat. Their direct answer. This is a Leonardo da Vinci, not a surgeon, but he drew the first thing. What was the first depiction of thyroid? Okay, so that's a Leonardo da Vinci. And after that, somebody drew. This is not a quiz, but I'm just telling you. This is again a painting by Michelangelo in Sistine Chapel, and you can see him when you drew this. He made a picture where he showed there's a thyroid. So they all said that maybe he was also sketched after Leonardo. All right, the next question goes to C. Take this. I'm giving you a hint also. What is his contribution to transplant surgery? Look at this gentleman. What was his contribution to transplant? Time starts now. I've given you a hint that this is a person who's related to transplant. What is his contribution to transplant surgery? Time up. So team D, E, F, A, B, G है, G, H, first, next A, B, C, हो गया, okay. How you should know this man. Okay, if I show his contribution, you'll understand what he has done. He is a man behind the cyclosporin, what he has done. Cyclosporin was, he is known as, he died just last year. He is Roy Yokalny. He's a British surgeon. He was the first liver transplant in Europe in 1968. No, but not in the world. He did only in Europe. The world somebody else was done. He's the first liver, heart and lung transplant in 1987. The first intestinal transplant in UK in 1992. He did the successful combined stomach, intestine, pancreas and kidney cluster transplant in 1994. Who did the first liver transplant? Not he. The credit does not go to him. No, that's not the quiz question. He was not the person. He was basically doing all these things, but the thing I wanted to tell you was, he was a man who did so many transplants. And the last thing is, if you see this picture, there's a painting. He is a person who paints, a fantastic painter, and what he used to do is, apart from transplant, if somebody goes to him, he'll make him sit and make a painting. So he has made paintings of his own patients in his waiting room. So he used to be a fantastic, and he does his self-painting. And he discovered cyclosporin. The next question is D. Look at this picture. Who is he? No, don't know his whisper, know this thing. D. Time starts now. Who is he? Pass. Okay. E. F. नहीं, inventor तो नहीं है. What is he? What is E. F. F. G. Who is he? H. A. B. C. तुम्हारा हो गया ना? हाँ. But the question is, who is he? I wanted the name. I don't want to say first robot तो वहाँ दिख रहा है. So I don't want you to say robot. Robot तो दिख रहा है. Oh, who is he? Not Mishra. थोड़ा सा हट गए हो. He is basically a Sudhir Srivastav. Dr. Sudhir Srivastav. He is a cardiothoracic surgeon and he was the person behind SSI. SSI is the company who did the first robotic surgery in India. So his everything, this is Indian round, so you must think of India only. He was a person who, he is the SSI is the thing which has the Indian thing. He's the first robot in India. And I happened to meet his son, and that is where the SSI's board had the MGM's logo when I went there. So that's Sudhir Srivastav. The next question is, who is going to get the next question? You. D. E. Okay. Look at this picture. Don't answer. Look at this picture. All right. Now, who the first surgeon to win a Nobel Prize? Who is he? Time starts now. Look at this picture. And the first surgeon to get the Nobel Prize. Okay. F. E. F. G. Pardon? All right. I think we'll give the bonus marks to them. This is Emil Theodor Cocker. Okay, name is Cocker is enough. He was instrumental in doing the thyroidectomy. We got the Nobel Prize in 1909 for pathology, physiology and surgery of thyroid. Okay, the next question goes to F. All right, F. Look at this picture. Who discovered the procedure? You know the procedure. Who discovered the procedure? Obviously, procedure is, you can see this procedure going on. What is this procedure? Some stapler going on. Next, EFG, H, A, B, C. Obviously, this is D, E, F. हो गया. How can you not know? What is this procedure? At least name the procedure. Stapler hemorrhectomy. So who would have done this? This is only this is known as Longo's hemorrhectomy. Okay, Antonio Longo's. This is discovered by Antonio Longo. That's with me. That's not. He's from Italy. So this is known as Longo's procedure. Okay, stapler hemorrhectomy. All right. The next question, very interesting. Who's going to get the next question? G. अयो जी थोड़ा आराम से सुन के बोलना ठीक है. I'm going to put this picture. Now I'll give you all the history. You don't have to bother with the history. I'm showing you a picture of Mark Ravitch, who is a surgeon, author, teacher, and soldier. He took part in World War II. All right. He was basically a surgeon, of pediatric surgeon basically, and he was the person who discovered the Ravitch procedure. That's a procedure we do for pectus excavatum. All right. So he was a person. He was also the person who said, because being a pediatric surgeon, he was also the person who said that barium should be given for the reduction of intussusception. Okay, so that was his idea, that in a child patient, don't operate, give a barium and see if the intussusception can be reduced and the surgery can be treated. But that's not the question. He also wrote a book, Second Thoughts of a Surgeon, Carmageon. Okay, the question is, who's getting the question? You. G. What is the meaning of the word Kermit-Gion? What is the meaning of this word Kermit-Gion? सारा हिस्ट्री में दे दिया, तुम सर एक उसका बुक का ये बोल रहा हूं. Next, A, B, C, D, E, F, G हो गया. So this word, I'm going to show you a new word. This is a bad-tempered, difficult, cantankerous person. जिसको हिंदी में बोलते हैं सनकी. So that's the book he wrote. Okay, next. H, who is H? All right, H, look at this picture. I'm not going to say anything. Look at this picture. Okay. Question is, your time starts now. Who invented this position? Who invented this procedure? Time up. Next. A, B, B. All right. We'll give the answer to them. That's known as Sims. Can you know the full name of Sims? The Vice Chancellor sir is sitting there. So anybody knows the full name of Sims? No. And what was his profession? Was he a surgeon? Even that you don't know. All right. He was not a surgeon. What was he? I said Vice Chancellor sir is sitting here. All right. Sims is a man. I'll come to that again. He was a man who did this vesicovenal fistula, who has got all sorts of speculum. He has got all types of sigmoid dilators. But that's not the end of it. He is being criticized widely because of, he is known as father of modern gynecology, but then he is criticized because of his experimental work on the blacks. Okay? On somebody he has done, he is a man who is known as Marion Sims. On somebody he has given without anesthesia and probably operated on a vesicovenal fistula without anesthesia on the same lady for 37 times. All right, so the blacks, because of his work, experimental on the blacks and all, he treated them as guinea pigs. Huh, sir? Bonus. Don't contradict with Dr. Sharad. He is a very good scorer. So don't, if he gives a mark, he's given a mark. Don't contradict. So that's the same. Okay, next question goes to audience. Huh? All right, audience mein koi hai? All right, again the question goes to who coined the term cholecystostomy? I throw it to the open. Who coined the term cholecystostomy? Okay, even the participant they will not get points, but anybody can answer this. Who coined the term cholecystostomy? Okay, बोलो ना तो चालिए रखते भाई जेनेटा के तले तो चलते ना करना. Okay, the answer is it was coined by again the same person, Marion Sims, and that's the paper which he has published in British Medical Journal in 1878. Again a gynecologist. All right, so cholecystostomy is a term which has been again coined by Marion Sims, known as father of gynecology. So at the end of round 5, Sharad scores.
Team H is leading with 20 points. Team B and C are with 15 each, and Team F and G are with 10 points each.
All right, so now we start the round 5. Round 5 is basically a quotations And nicknames. Who is going to get the question? A. All right, A. This is the time when you have to tell me the quotations and the nicknames. I'll put a quotation and then your time will start. So read the quotation. After I read the thing, only then the time starts. The quotation is, a successful surgeon should be a man who, when asked to name the 3 best surgeons in the world, would have difficulty deciding the other 2. Who said that? A successful surgeon should be a man who, when asked to name the 3 best surgeons in the world, would have difficulty deciding the other 2. Who said that? A. A, you have to give this answer. B. Pardon? C. D. E. F. G. Pardon? H. The answer is Denton Cooley, the famous cardiac surgeon. All right, he was a man who did that. Okay, now the next question goes to B. B, get ready. Your quote comes now and you should get that. The question is, I know a more than 100 surgeons whom I will cheerfully allow to remove my gallbladder, but only one to whom I should like to expose my inguinal canal. Who said this? Who said this? I know a more than 100 surgeons whom I will cheerfully allow to remove my gallbladder, but only one to whom I should like to expose my inguinal canal. Who said this? Next. Pardon? Shoulders. Okay. C, done. D, E, F. Okay. G, H, A. No. The answer is William Henrich Ogilvy. All right. In his name only you have Ogilvy's syndrome, which is known as intestinal pseudo-obstruction. All right. No talking between the thing. We'll just. So now the next question goes to Team C. Get set. Team C, read the quotation. No disease of the human body belonging to the province of the surgeon requires in his treatment a better compilation of accurate anatomical knowledge with surgical skills than hernia in all its varieties. The quotation is, no disease of the human body belonging to the province of the surgeon requires in his treatment a better combination of accurate anatomical knowledge with surgical skills than hernia in all its varieties. Who said that? You want to try? No. Okay, then D, E, F, G, तुम क्या बोले? अरे पास्टन बोल के कोई नाम होता है क्या? पूरा नाम आगे पीछे बोलो यार. A, B, C, no. Ashley Cooper. Cooper's ligament. That's a book which he has written. In this, he has told this quotation. All right. Next is D. All right. Questions to D, Team D. D ka hai, tum. All right. This is a very interesting question. I don't know whether if you have known the surgical history, you'll know that. Don't start the time. This was in July 2nd, 1881. All right. Somebody said, yes, I shot the president, but his physicians killed him. The president who was shot was James Garfield of US president, who was shot. Okay. When the assassin was called, he said, no, I shot the president, but I didn't kill him. The killing was done by the surgeon. All right. So that's the story of an US president. I'm not saying Indian or UN president. How did the US president die? This was the book which is written, and this is a real thing, and you can see all the names here. How did the US president die? If you tell me that, that's enough. He was shot, but he did not die because of that. E, F. All right, we give it to him. It's a direct question. So the answer is yes, he died because of wound infection. And you know the reason for the wound infection? The US president was shot, and he had a wonderful surgeon. All right, the surgeon was Dr. William Bliss. Okay, and the William Bliss was the real, the President Garfield used to believe everything on him. It was his family doctor. Now, William Bliss said, everything I'll do. He said, no review, nobody, no other surgeon should see this president. He's a US president, I'm the surgeon, nobody else should come. He did not call anybody. Every day he used to have his bare foot because the bullet has gone. So he used to put his finger inside and deep the president. Okay, find the bullet where the bullet is. Bullet was not found anywhere. With his find the finger, there was a complete sepsis, and the president went on this thing. He did not allow any second opinion. He did not allow anything. The patient went into real sepsis. Then what he did? He published. He fed the president from the rectum. Okay, and he published this paper. He said, because the president not will, I'll put the feeding thing to the rectum. So can you believe this is happening to a US president? Okay, he was fed to the rectum and he died. But then you know what is that? He did not know what to do. Then he called somebody called Alexander Graham Bell. What did he do? Telephone. So he was the man behind telephone. The phone was this thing, and he was also the person who had something called a metal detector, what in today's term we call a C-arm. All right, so he had, because he was doing telephone, so he had something called a metal detector. So he called him, and he said, you look at it, where's the bullet? But this Bliss fellow was so this thing, he said, you should only see the right side of the abdomen, I will not allow you to see the left side. By that time, the bullet has gone to the left side, but he did not allow. And he was sleeping on a metal coil bed. So even if the metal was seen, there was a confusion by Graham. He was not able to, he said, he's sitting, why don't you make him sleep somewhere else? No, I will make him sleep only in the metal bed. The US president was not allowed to sleep anywhere else. If given a choice, Graham Bell would have said this is a bullet and they would have taken it out. But he will say, no, I will not allow you to touch anything else. I will not allow you to see anything else. And the president died. The next question goes to, all right, you know this man, you read his book, all right? This is Sabiston, and the name was David Cotton Sabiston. You read his book every day. Why was he called as TM? He had a nickname, TM. Sabiston had a nickname, TM. Why was he called TM? डेली पढ़ते उनका बुक क्या लाइब्रेरी में जाके नेक्स्ट F G A H H है क्या नहीं H है try you want to try no A B C okay, I'll give the answer. The TM refers to is the man. Okay, because Sabiston, he was such a man that that is known as a positive TN sign means his car is there in the parking lot. So all his residents and all used to see his car and say the man. I mean TM sign means his car is there. So you have to be always on your toes. The Sabiston has a passion for detail, cleanliness, and formality. Anyone found in the scrub clothes outside the OT suits flirted with expulsion. He used to expel them. If you are wearing your OT dress and God, he will expel them. Once the chief president, who had invented the world's first artificial heart, was sent home, okay, because he was wearing a casual trousers. So he was so strict that everybody, all the chief used to call him as TM, the man. Thank you, sir. The next question goes to F. All right, F. His work in colorectal surgery earned him the name King Rectum. And you can see this probes, fistulous probes there. All right? Who is he? Time starts now. His work on colorectal cancer surgery earned him the name King Rectum. And that's a fistulous probe you use in fistula nano. Okay, next. Next is G. No, the H. John Locke. Okay. Full name? Anything else? All right, we'll give it to him. He said Lockhart, so I don't know. I cannot take him. He's already given the answer. The answer is John Lockhart Mummery, and he was the person who did for this fistula. He was a person who is known as King Rectum, and he developed sarcoma himself, for whom Joseph Lister did the amputation. All right, and that's the paper on which he has a cancer rectum thing, and this is the name John Lockhart. So give the bonus point to them. The next question goes to which team? G. G, I think you should get this. There are many surgeons who could have done the first heart transplant, but he was the one who had the courage to take the opportunity and do it. It was said by Denny Friedman. Who was the surgeon and which one was it? There were many surgeons who could have done the first heart transplant, but he was the one who had the courage to do the opportunity to do so. Who was the surgeon? Next. Whose turn was that? GH. A. B. C. हो गया? Yeah, who gives the answer? I think we give to them. Bonus part de do usko. This was a Christian Bernard who dared, and he did the first heart transplant in December 3rd. That's a thing which came out in the newspaper. The next question goes to H. H. H, ready? Who is known as surgeon with the fastest knife? Who is he? He is known as surgeon with the fastest knife. Who is he? H. Next, A, na? A. He is known as surgeon with the fastest knife. B. C. D. E. F. Okay, we give it to them. He said Liston. He is known as Robert Liston, who he was so fast that he had a thing of doing 300% mortality. Once he did a surgery where the patient, he did an amputation in 25 seconds. It was so fast the patient died. While doing the surgery, he cut the finger of his assistant, he died. One person was watching the surgery, he died of cardiac shock. So three people died watching one surgery. There was 300% mortality. The next question goes to audience. Okay, audience, skip. All right. All right, now we come to the last round.
Total.
Give the round scores.
So team H is leading with 25 points, and in second place are team B, C, and F with 15 each, and then team D and G with 10 marks. My question to you, sir, is if there's a tie, what is going to happen in the end?
We'll see. We'll see that. We'll do.
ना सर्टिफिकेट नहीं आमा के नाम लिखते हो तो सर्टिफिकेट नहीं जो दी अपनी
ठीक we'll see that. So that we'll do that thing. 6, who's getting this question? You, A. A is getting this question, okay. A, look this picture. This is a picture from Bailey and Love, current Bailey and Love, where they have made a picture of the discrete lumps in breast. And if you read this classification, is known as Lucknow Cardiff breast nodularity score. Who discovered the Lucknow Cardiff breast nodularity score? If you read this thing, this is the current Bailey and Love, and there is a picture from Bailey and Love where there was a Lucknow Cardiff. Who discovered the Lucknow Cardiff? This is from Bailey and Love. B, C. Bailey and Love देखने से तुमको मिल जाता है उसको. D, D, E, F, G. Yes, I think they get the thing. They said that Sandeep Kumar. They get the thing. So we'll have this. So that's Dr. Sandeep Kumar, who's the associate. He was once the editor of chief of Indian Journal of Surgery. So the next question goes to D. B. B, if you read this book, this is the first encyclopedia in the world, which is known as Kitab al-Tashrif. This was written by somebody called Abu Zal al-Zalahawi. He is known as father of modern surgery. He was a person who discovered catgut. Known for the father of modern surgery, and he was pioneering in the 10th century. He introduced the catgut, stitches. He has done a lot of things. He was one of the pioneers to do a lot of things. Now the question is, how is India connected to al-Zarawi? He was the first, that al-Tashrif is the first encyclopedia in the world of surgery. How is India connected to that? It was, he did it in somewhere in Spain. That time the Moorish thing was Spain. Next team. No. How is India connected? Not Akbar. See, D. Pardon? How is India connected? That thing was, he wrote somewhere. How is India connected? E. F. Yes. What library? His library now. What is the thing in the library? I think we'll give it to them. Let them give to A. A is opening their account. So let them have the score. A is opening their account. So yeah, this Al-Zarawi is basically the man. This book, 2 parts of the book has been taken out. This is a book written 1001 AC. 2 parts of the chapter has been kept in the Khuda Bakhsh Library, Patna. So if you happen to go to Patna, you can see these 2 books are the first encyclopedia in the history of the surgery, in the history, kept in Patna. Next question goes to C. C. This I'm talking about Dr. John Rosai. He is a pathologist, but he wrote Guiding the Surgeon's Hand, and he wrote in the history of American surgical pathology. He's John Rosai. The question is, what disease is John Rosai associated with? C. What disease? If you see this, he's the man who has, obviously it has to be something surgical. I'm asking you, that's why. Next, C, D, E, F, G, H, A. Nobody? His name is the disease called Rosai-Dorfman disease, which is basically sinus histiocytis with massive lymphadenopathy. Okay, we can see this. There's a huge lymph node in the neck, and that's why his name was discovered. Sir, you want to add something? No. Okay. Okay. Next is D. Who is D? All right. D. This is a huge question, so I'll read this for you. His most famous surgery was vaginal hysterectomy. One minute. His most famous surgery was the first vaginal hysterectomy in 1813. I think sir is there. It was carried out by a 50-year-old multiparous woman, possibly with the cancer of the cervix. He performed his feat without anesthesia or an assistant. At one point, He was left clutching the bleeding area in his left hand. He is touching the left hand, holding one end of the ligature with his teeth, tying the other hand with the right hand. He claimed a careful dissection as to not open the peritoneal cavity. There was considerable hemorrhage, but amazingly, the patient survived. Revived with a splash of water, because no anesthesia, to the face. After the surgery, the specimen was lost, and his achievement was doubted by the medical fraternity until 26 years later, when the patient died and the postmortem examination confirmed his statement. All right, so no assistant, no anesthesia, and he did this vaginal hysterectomy. Who is he? Team D, E, T, try, pass, E, F, okay, give it to them, bonus point. This man was the man who invented your Langenberg retractor. Every time you are seeing this Langenberg retractors, remember this man. Okay, he was the person who discovered this, and he was a very fast surgeon. He seems he used to so much speed that if you take your, it was saying that in turning away from the, somebody was taking a snuff and he finished the shoulder amputation. He was so fast. Okay, next question goes to E. Look at this picture. Okay, look at this picture. Who is a surgeon and what is the significance of this painting? Who is the surgeon and what is the significance of this painting? Please name the surgeon. E, F, G, H, A, B, C, no, D, क्या बोला? E, हो गया ना, सबका हो गया? तो हो गया तो This is Theodore Billroth operating on the painting surgery done in Billroth. But the problem is not that. I'll show you the picture again. You see, this is the first time the surgeons they are allowed the white coats. What we are wearing the aprons. First time, this was Billroth who said you have to wear a white coat and come to the surgery. So the white coat was done by him. F. F ready? Simple question. What is tomophobia? Time starts now. What is tomophobia? Very simple question. G, H. Okay, give it to them. I think tomophobia is fear of surgery. Correct answer. Next team is G. G, look at this picture again. This is a publication I'm showing you. All right? All written in language you may not understand. Okay, look at this publication. And you can see the year 1882, 27th November, everything you can see that. Who is the author of this publication? Look at this publication. Who is the author of this publication? Who is the author of this publication? Okay, next team. Next team is whose? Sharad? H. A. B. C. D. E. F. E, F, G. हो गया? Okay, you read this question answer. Here I am going with the thing. What's name? Who is he? That's the first time cholecystectomy being published, open cholecystectomy. He is the man who performed the surgeon, and the first time open cholecystectomy was published in German. All right. Next question is this. Whose team is this now? You. Okay. Look at this picture. This is a picture from this book. All right. And the book is Hamilton Valley's Demonstration of Physical Science in Clinical Surgery. That's a picture. Anything in the picture you're seeing abnormal? That's not the question. Anything in the question? Whose hand is shown in the test book? Whose hand is being shown in the test book? Time starts now. See this picture again, somebody's hand being shown. That's a book I'm showing. Time up. Next is A. A, B. All right, give it to them, Sharad. They get the point. B gets the point. This hand is Hamilton Bailey's nerve himself. Okay, that's shown in this. Actually, he had lost his non-dominant index finger after a infection while he was doing a surgery as a registrar, and they amputated the finger. So it is his own hand in his book which they have taken. Okay. This is the audience. I think we'll give it to them. I think we can end this quiz. Sharad, please tell the scores.
Because Team H is the winner with 30 points. Team B and G are a tie at 20, and Team C and G are at 15.
So we have to have a
certificate. Utna nahi hai re. Whatever you say, sir, I have no issues.
No, we have one first team, two second team, is it? Third one team. Third was the two teams. We have certificates? We don't have certificates. Do you want to share the cash money? I am fully for encouraging the postgraduates, provided you are. हाँ सर्टिफिकेट उनको दे, पैसा उनके लेंगे. Sharad, can we have a tiebreaker question then? Huh, sir? We'll have one tiebreaker. But I don't have so many questions. F.
So whoever raises hand will get the first. Yeah, the other one will get other one automatically gets the second, third position.
Okay, all right, accepted that.
Between B and F.
Where is the B and F? B. Yeah. So you have to tie. All right. So that's the question. I am showing you a picture where the French surgeon Henry de Mondeville, and you can see the pictures. You can see his. He has painted a picture where he is taking the skin out. Okay, and he's showing hanging and going. That's the thing of a surgeon who has painted in the year of 12, 16, 13, 20. The question is, what was the contribution of this man in surgery? What was the contribution of, what was this man's contribution? And you can see that that man is such a person who is drawing himself, the skin being taken and hanging into like that. So what was his contribution to the surgery? Obviously, he is not a normal person. That's a surgeon. And he is having this thing. Time. Hey, time. Any guess? At least anybody wants to take a guess? Okay. Our question. করে দিচ্ছি। इसको थोड़ा ऑफ करना, इस कैमरा ऑफ करना, बैक करना पड़ेगा मुझको। इसमें नहीं दिखना चाहिए, এখান থেকে দেখা যেন না আসে, এখান থেকে না দেখতে পারে। हाँ वही तो मैं बोल रहा हूँ बस। हाँ ठीक। All right, if you happen to, the only time questions, if you happen to go to the Fifth Avenue in US, the New York Academy of Medicine, you find something like this kept. This known as papyrus. I'll give you the answer because the time question I'll give you. There's something, one of the famous papyrus being kept in this place. All right. What document is present or what papyrus is present in the New York Academy of Medicine? If you happen to go there, you find one of the most famous papyrus for the surgeons kept there. What is the most famous papyrus for the surgeons? Where the entire history is written. Surgical history. That's the only place which is there. Papyrus means from the Egypt. Try any papyrus name. If you can give me, I'll give the answer. Any papyrus name. This comes often in your belly love. This papyrus name comes everywhere because every history comes from there. That means from Egyptian thing. Any papyrus name, the most famous papyrus in the history of Egypt, they have stolen it and they have kept it there. Even today's seminar, that's a breast, has been taken from there. They were the people who took out that breast CME's, breast cancer's treatment those days. Any papyrus, if you can name, I can give you the answer. No, any other? नहीं ना, तुम लोग का हो गया, तुम लोग का नहीं है. चलो चलो done. चलो. The answer is Edwin Smith papyrus. That's the most important papyrus, and how can you not know him? That's a CA breast is also there. If you read your CA breast, you would have got the answer. So we finish this. You declare the result, Sharad.
First team is team H.
You name the members also.
Yes, Dr. Divakar. Sir आ जाएंगे तो एक बार.
बोल दो अभी सबको सुन ले.
Team F is H is first, team F is second, and team B is third.
सर्टिफिकेट लिखे दीजिए. सर्टिफिकेट लो. लिखे. और इधर के दो ना कैश. ओके ओके. আর অনলাইন গুলো
ওখানে দুটো ছেড়ে দেন
তারা চাইবে তো চাইবে তো দুটোই আছে নাকি হ্যাঁ লাইন করে দাও কটা আছে ওখানে ये ऑनलाइन করে দেওয়া যাবে দিয়ে দাও না স্যার এসছে সবাই ফটো তুলবে সবাই দিয়ে দাও সবাইকে দিয়ে দাও the online quiz winners are there Shivank and the faculty Sharad is there and then another faculty Dr. Anup is he there can somebody call him to come because registrar is coming, so it will be nice to. Can somebody call Dr. Anup from his unit to come? তুমি নামগুলো বলে দিও बंद कर दो। আমি কি করব? না রেজাল্ট কোথায়? আমার কাছে কোথায়? HF. Team H, are you there? HF. All right. You only need 2 members, huh? And B. B. Okay, so all ladies. এটা কি ফার্স্ট থার্ড প্রাইস? এটা কত টাকা? 3টা 9 লাখ প্রদান। तुम्हारा पूरा नाम क्या है? राजकमल सिंह। ऑनलाइन ना कि ऑनलाइन तो दी दो ऑनलाइन এখানে আছে নাকি অনলাইন গুলো দিয়ে দাও তাহলে। Thank you, sir, for coming. I welcome the registrar, Mata Gujri University, for the final results. We had an exciting day. Sir, we had 6 rounds of quiz, and it was wonderfully played by the, and that's the score. We had a lot of good answers coming from the audience, and I welcome him for giving the awards to this thing. And thank you, sir, for all those people who have not listened. And let me tell you, when I went to, myself, Professor Hinmay sir, Professor Sehwag sir, and Sharad went to his chamber to ask him for the rewards for the quiz. He was magnanimous enough to tell us that first prize 10,000 rupees. I think that's a huge amount given by the registrars. Please put in a good, and the second prize 5,000 and 3,000. Thank you so much, sir, for encouraging the postgraduates in this, and it was a huge source of encouragement to all. Sharad, please declare the results.
Yes. I would like to request Professor Asitadev Roy sir, Vice Principal, MGML College, to kindly come on the stage and give away the third prize. Third prize goes to Team B, Dr. Simran Kaur, Dr. Aprajita, and Dr. Rakhi Kumari.
That's all ladies team.
Round applause, please. I now request Vice Chancellor, sir, Honorable, Professor Sudhir Bose, sir, Honorable Vice Chancellor, to give away the second prize to Team F, Dr. Raj Kanwar Singh and Dr. Vishal Kumar. Please clap.
Clap nicely. Yes, sir. आपका यूनिट सर. शरद.
I now request Dr. Ichit Bharat, Honorable Registrar, Mata Gujri University, to kindly give away the first prize to Team H, Dr. Diwakar Kumar, Dr. Punardeep Singh, Dr. Ronak Sinha, and Dr. Shahnawaz Alam. Please clap.
Come, please join in that place. खड़े हो जाओ सर, फोटो ले लो सर. Thank you, sir.
Thank you so much, sir.
Thank you.
Yes, sir.
Honorable Vice Chancellor, Dr. Sudipto Bose, sir, all the faculty members, delegates. First of all, I would like to welcome all the resource faculty who have traveled, I think, from all over the part of India to make this CME a grand success. From last 3 months, we have organized more than 6 workshops and CME. Not only state level, but national level. So this is one of the most important part for any institution, for any medical institution. Organizing CME and workshop in national level is most important as per the regulation by the National Medical Commission also. So we are trying to improve our academics. We are focused on academics. Both clinical and academics is most important for any postgraduate or for any faculty members. So I would like to congratulate Dr. M.M. Haider, the Honorable HOD, Department of Surgery, the organizing, I think, Chairperson Dr. Hiranmay sir and organizing secretary and all for organizing this CME. And I will also like to inform that we will also try to include some international faculty, delegates from other country to our institution for organizing CME and workshop. Thank you.
Last memento for Kaushik sir, please. Quiz. Thank you so much, sir. Thank you, sir. Last message to be given by Dr. Hiranmay sir.
Sir, 1 second, sir. 1 second. Just do 1 minute. Dr. Sharad has to not take the certificate. So I'll request Professor Saival Mukherjee, Hiranmay sir, please give the certificate honor to Dr. Sharad Changdan. Na. Online quiz.
Shivang Nungta and Dr. Gurbir Singh. Dr. Shivang Nungta and Dr. Gurbir Singh, please take your certificate. Gurbir, second. Shivang, jaldi. This is. And Dr. Vishal Kumar also.
Next. Dr. Vishal.
Now the concluding remarks done by organizing chairperson.
Good afternoon, everybody. It is customary for this CME to give a concluding address to all the dignitaries and the PGTs present over here. We are already late and everybody is hungry, so I don't want to prolong my address. So we started yesterday with a very high note, but right now we are slightly depressed. Our guest teachers has already left. They will have to catch the train. So last year we tried to organize this CME, but because of that bad incident in Kolkata, we couldn't organize this. So this time, after crossing so many hurdles, I think we have concluded this CME successfully, though there was some little bit of idhar udhar hua. So, and that's why I think our honorable director, sir, who gave us the permission to hold this CME in this institution. Also, I am thankful to our registrar, sir, for giving us all sorts of supports. Whenever we have given, oh, sir, ho jayega. So, and thanks to our Vice Chancellor, sir, our principal, our Vice Principal, all the other faculties and all PGTs who have come, our institution, and who has come from outside, as well as all categories of staff. They have helped us enormously to finish this CME and to so that we have successfully completed the CME. I am not going into the details. So thank you very much, and we are looking forward for other this type of CME in future. And as Professor Dr. Ichit has said, that he wants to bring some international faculties, and that will put another feather in our cap. So thank you very much.